Okay, guys, so get ready with your answers. What's your first diagnosis? But that sort of a thing, your first diagnosis has to be a right-sided testicular torsion. Differential diagnosis, torsion of the hydatidal morgagni, epididymoitis, or trauma. What will you do for this patient and why? And why does this condition occur? Is there any long-term complication for this patient? Now, he's a 10-year-old. What the important thing, this is a minefield because in an MRCS, you will actually have to do this counseling. Telling the patients, the parents, regarding the possibility of infarction and subsequent orchidectomy, that the operation will be also done, that you will fix the left side and it will be prone to the same condition. You need to warn about long-term complications and would going for an immediate operation, ideally would try and get in between 4 to 6 hours. You know, that is a critical period of time beyond which the testes infarcts. You need to do an incision and a sort of an incision which will allow you to access both the testes, layers of the tunica to expose the testes and untwist. Do a jagule sort of a procedure, which means you invert the sac and then you do a 3-point fixation with non-absorbable sutures after orienting the testes right. And you know, while in the process of orientation, the sinus, the epididymal sinus slides laterally. So you need to do that. Sinus points laterally. The tail of the epididymis is down below, head on the top. So you need to remember that, and you will do a 3-point fixation with non-absorbable sutures after orienting the testes. And post-op analgesia is something that you also need to talk about, particularly if you're going for your MRCS. So why does this condition occur? Inversion, testes rotated to lie transversely upside down, or sometimes you have a high attachment of the tunica vaginalis, like a clapper in a bell. And you sometimes have a separation of the epididymis from the body of the testes, which is called a pedicular torsion. You know what the pedicular torsion is all about. So I'm just going to draw you a picture of what pedicular torsion is, that you have the testes out here and the epididymis, instead of lying close by, so you have the epididymis like that, and it sometimes twists around out here. So that's called a pedicular torsion. So you sometimes have a pedicular torsion. So just remember that, guys. Long-term complications following this: reduced fertility is a problem. An ischemic reperfusion injury damaging the blood testes, barriers, antibody formation against even though you've done a successful operation. So you need to explain that to the parents. That is very important for So give you exactly a minute and a half for this. Please remember that particular little phrase, that his sensation is slightly diminished. So please remember that. Right, guys, so answers. This patient has obviously an femoral artery embolism. have a history of cardiovascular disease, peripheral vascular disease, family history of similar disease and clotting problems. You will check his pulse for sinus rhythm, peripheral pulses, including with a handheld Doppler, assessment of motor and sensory status of the right leg, and you've obviously discovered that his sensation is diminished, so your diagnosis is an acutely ischemic limb, which appears viable as motor function is intact, and possible early compartment syndrome caused due to femoral artery embolism. So you need to know what to do. In it, you will do arteriotomy and get that clot out. The way to do it is to put in that's the femoral artery. You will actually put in an incision. You will put in something called a Fogarty catheter, which is a catheter with an inflatable balloon at the end, and you will put that in and take the clots out all the way. You will also put it out and make sure that the clots, there aren't any clots proximally. If there's a good run in, so you might want to put in a Satinski clamp out here till you finish that. Having finished that, you will put in a heparin solution into the distal end and you will close this up. Now, in the process of closure, you cannot close it up end to end, otherwise it will create a bit of a narrowing. So you will need to harvest a vein patch and close the defect with a vein patch from a surrounding superficial vein. Usually, I mean, the long saphenous lends itself very easily to providing venous patches. So you will put in that venous patch out there and then stitch it with continuous fine 50 or 4050 non-absorbable sutures, monofilament sutures. So that is something that you need to do. And in addition, there's a possibility of a compartment syndrome. So you will need to do a fasciotomy. Anterior incision is 2 finger breadths lateral to the anterior border of the tibia to avoid the peroneal nerve, and it gives access to both the anterior and the lateral compartment. So 2 incisions are required. You do an anterior incision and a posterior incision, and you drain all the 4 compartments. There are 4 compartments in the leg which you have to drain. So anterior incision, 2 finger breadths lateral to the anterior border of the tibia to avoid the peroneal nerve, giving access to anterior and lateral compartments. I'll give you a picture which shows it beautifully. And a posterior incision, 2 finger breadths posterior to the medial condyle of the femur and the medial malleus, as to avoid the long saphenous vein. This gives access to both the superficial and the deep posterior compartments. And that is the thing. So that's the medial fasciotomy and the lateral fasciotomy, or otherwise the anterior or the posterior, which is because it could be called anterior and posterior because that accesses the anterior compartment, and this principally accesses the posterior compartment. So that is your position for a posterior or a medial fasciotomy, and your position for anterior or lateral fasciotomy, your choice. So you need to open up both the anterior and the lateral with that incision, the superficial posterior and the deep posterior with that incision. Okay, guys? Right. Next. A minute, because I really need to speed up.
Sir, in that peripheral vascular disease, sir, embolism, sir.
Yeah.
Sir, if the vascular surgery is not available or it's not available, sir, then the medical management for it, sir, how can you?
You can do a streptokinase injection, but it's not really as good as doing an embolectomy. The definitive treatment is an embolectomy. isn't it?
Yes, sir. Yes, sir.
So ideally, given the scenario in an OSCE, you would give the ideal, isn't it? Rather than considering treatment which is not as good as that's a compromised treatment, isn't it? Putting in a streptokinase.
Yes,
Sir, in deep venous thrombosis also embolectomy is ideal, or giving this thrombolytic therapies, sir? Like
deep venous thrombosis, you see, the problem with a vein is that the flow is very slow, isn't it? So embolectomy isn't as remarkably, with an embolectomy, doing a femoral arterial embolectomy, if you've ever done one, it's dramatic and it's very satisfying when you do that. It comes back to normal immediately. With a venous thrombosis, usually you would try and avoid, unless it is a patient who you need to take the, who has been shedding thrombi into his chest. You would prefer not to do surgery, and you would prefer to treat them with medical management. Because if the patient has recurrent thrombi, you might need to put in one of those filters into the IVC. It's called a Mobin Adin umbrella. It's a sort of an umbrella-like implant that you put in. The problem of doing a venous embolectomy is that it always recurs.
Thank you, sir.
Welcome. So this is a patient who, let's start discussing this, because I think Ramonuj is going to be very upset. So that's a CCT. What's your diagnosis? What's the cause of the condition? How will you manage the patient? So if you look at this patient, if you look at this is the stomach out here, and that is the duodenum. So it goes up till there, and there's a sudden cutoff out there at the third part of the duodenum. So guys, this is superior mesenteric artery or the Wilkie's disease. The causes are either a high insertion of the ligament of Treitz, and a narrow angle of the superior mesenteric artery coming off the aorta. As you know, the superior mesenteric artery crosses the third part of the duodenum, just where the uncinate process and the uncinate process of the pancreas. In the majority of patients, the normal angle between the superior mesenteric artery and the aorta is anything anywhere between 38 degrees and 65 degrees, because there is a bit of a mesenteric fat pad. People going for a crash course of weight loss sometimes lose out their mesenteric fat pad. Keto diets are known to cause that. So it's, note of caution. The loss of the mesenteric fat pad causes the angle to reduce to 6 degrees, and the aorta mesenteric angular, that should be the distance to less than 8 millimeters. So when it does that, it presses, it's a sort of a pinchcock sort of action against the, in between the superior mesenteric artery and the aorta, as a result of which, if I can, that is the aorta. Oops. That is the superior mesenteric artery, and you have the duodenum. But here, normally there's a fair bit of a gap, and the duodenum can work normally. But if you can well imagine that if now you have a situation where you have the artery coming in close, that angle is less than 6 degrees. So you have the duodenum pressed. So that is classic Wilkie's disease, where it gets pressed. And some of the problem is because that is the C loop. If you raise this up too high, that's a DJ flexure. And why is it high? Because the ligament of Treitz is higher. So if that goes high, that will hinge, that hinges against the superior mesenteric artery, isn't it, guys? So that's the problem. So next few slides on that, actually. So,
sir, can you please get back to the slide? How did you diagnose that superior mesenteric artery syndrome?
Okay. So that's the stomach. choose another color. That's probably the pylorus, the region of the pylorus somewhere out there. And I'm going to choose another color and let me choose something dramatically different. Maybe choose green because it's full of bile. So that is the duodenum. Can you see the duodenum going down out there? The stomach won't reach the anterior surface of the kidney, isn't it? So if it's reaching the anterior surface of the kidney, what reaches the anterior surface of the kidney? So if I were to draw the kidney like that, what reaches out there is the C loop of the duodenum. Okay, that's the C loop of the duodenum with the pancreas in between and the artery crossing somewhere out here. So now if you can well imagine, we are taking a complete slice throughout here. And the slice shows you that that is the duodenum going right down in front of the kidney, and that is the arterial complex. This bit is the arterial complex. Okay, that bit is the arterial complex. And that's the area of narrowing. So now you have a situation where your duodenum is hugely distended. It can't expand this way because the pancreas is there. It has to expand laterally. So that's, you can see that that is the duodenum distended. Okay? Right, so I'm going to go forward. So that is the ligament of Treats. I've taken it off Bloomgard's book, and you can see that if the ligament of Treats is high, you get a very narrow angle through which the distance is less than 6 millimeter and the duodenum gets pressed on. So one of the treatment is that you cut that and slide it down. You put in 2 fingers, and that used to be one of the treatments, but that's the sort of treatment that you tend to do. You cut the ligament of Treats and slide the duodenum down. But actually, the better part is to anastomose that part of the distended duodenum to the jejunum. So think about it. If you lift up the transverse colon, so that's the transverse colon which we have lifted up. That's the mesocolon, transverse mesocolon. What you can see distended out here is the end of the distended duodenum, where because remember that the middle colic comes from the superior mesenteric, so that is your superior mesenteric ileocolic going down, and that's a transverse, that's a middle colic coming from there. So you can actually see it out here. So the best operation is to expose it through that area and do an anastomosis with the jejunum. So that's a duodenojejunostomy. And sometimes people will ask you, why not a gastrojejunostomy? You will condemn the patient to a lifelong bilious vomiting because bile will then have to go up into the stomach and go down. I think I've got another slide out here. Shows that. Yep, there we are. So you do a proximal duodenum, you do a bypass out here rather than to the stomach. Because if you do it to the stomach, think about what happens to the bile. The bile has to go up. If you've done a stoma out here, so the bile has to travel up from here into the stomach. It never goes down there. It always goes up this way. So you land up with French bilious vomiting, which sometimes kills the patient. So you actually have to take down that gastrojejunostomy and end up doing a duodenojejunostomy. That's yeah.
So can we do duodenostomy, sir?
One of the most difficult things, that duodenum is stuck behind, isn't it? Think about it. This is the first part. This is the second part of the duodenum. That's the third, junction between the second or third, actually the third part. The fourth part is retroperitoneal, isn't it? So doing a duodenostomy is one of the most difficult things out here. Think of what structure do you think is out here? On top of that, DJ, what structure? Something that goes like that, comes in like that.
Pancreas.
Yeah, so do you think it's going to be easy? It's not easy at all, guys. So it's far easier to get this part of the chest, bump and do anastomosis and get away, isn't it?
Yes.
Far easier to do it out here, isn't it?
Yes, sir.
Correct. So that is what you need to know, not ever to do a gastrojejunostomy, guys. Don't ever do a gastrojejunostomy. So that's what you need to do. Okay. Right. Next. This is a very short one. I'm going to give you exactly half a minute for this. This was sneaky. This was professor's fun way of getting it. I managed to get one similar, but all our, special exams had this picture. Then by the time they realized we all knew, and they had to change it. Okay, guys, so you notice that this lady has the right breast, but the left breast shadow isn't out there. So this patient has had a mastectomy and post-mastectomy radiation. So this is post-RT fibrosis. So post-left lung fibrosis, thank God I've got the left and right correct this time. Post-mastectomy fibrosis goes by radiation. So other causes are chronic inflammatory processes, but that's always bilateral. Infections can be unilateral. Environmental agents, again, bilateral, like asbestos, silica, exposure to certain gases. Exposure to ionizing radiation, which can be unilateral, such as radiation therapy, treat tumors of the chest, and chronic conditions like leukoid or rheumatoid arthritis. So these are the causes of lung fibrosis, but single lung fibrosis is almost inevitably due to ionizing radiation. Prevention is the first step in managing RF, radiation-induced fibrosis. Since the dose of radiation, volume, and radiator are the most significant risk factors, limitation of these parameters is usually the first consideration. And in modern terms, you do a conformal radiation technique. Most of the radiation therapy is actually directed to the tumor rather than to the surrounding patient. This patient actually originally came in with locally advanced breast cancer, which was treated with RT downstage, and then she underwent toilet mastectomy. Due to its crucial role in radiation-induced fibrosis, you've heard of TGF-alpha, and this is TGF-beta, and its associated signaling molecules have been examined as therapeutic targets. Still under investigation, just remember that term TGF-beta. Additionally, a number of commonly used medications have been used, and this is of the radiotherapy department, including Gleevec, imatinib, tyrosine kinase inhibitors, simvastatin, enalapril, AC inhibitor, and dexamethasone, of course. So that's a small little OSCE. Right. So next one. And I'll give you, that doesn't have the question, so I'll give you the question. So that is your question. And I'll give you a minute. Ramnuj, this will be my last one, and then you can take on. Hi there, Ramanuj. Are you there?
Yes.
Okay, so I'll finish with this one.
Image collections are excellent, Sanjay.
You know I keep a stock.
A very good stock indeed.
Right, guys. So if you have the answers ready, these are stigmata of liver failure. I've been through them. So skin changes, nail changes. Now I'll show you the mnemonic. You're too close to your exams. So changes in upper limb, Dupuytren's contraction. Incidentally, just remember Dupuytren treated Napoleon Bonaparte's hemorrhoids. So that was his claim to fame, not his defect. And of course, the venous hum was by Prouvaille Baumgarten. Prouvaille was a French doctor. Baumgarten was a German pathologist. They described this venous hum. So actually, if you remember this mnemonic. It's the Oxford Medical Education mnemonic. A, B, C, D, E, F, G, H, I, J. A is for asterisk, not mine. Asterisk, ascites, asterixes, flapping tremors, ascites, ankle edema, atrophy of testicles. B is for bruising. C is for clubbing, color changes of nails. D is for Dupuytren's contracture. E is for encephalopathy or palmar erythema. F is for fetal hepaticus. G is for gynecomastia. H is for hepatomegaly. I is for increased size of carotids. And J is for jaundice. So just guys remember this mnemonic. Otherwise, I think it's a far easier way for you to remember. Except that one of the major things that hasn't been described in the Oxford Medical is spider angioma. So please remember spider nevi. So remember that. So so guys, just add spider nevi to this group of signs of chronic liver disease. So this is, you can see up here that there's if I can it goes blue, and you notice that is the portal vein going up. There's nothing going in out here, and it's all getting diverted into the splenic vein. And you can see that there are plenty of collaterals out here, around the lesser curve of the stomach, and that actually gives rise to varices which bleed. You also have a leash of blood vessels around the common bile duct, because the portal vein is complete, and these are called portal cavernomas. And portal systemic anastomas around the lesser curve of the stomach, and a huge splenomegaly. You can see that huge splenomegaly. So, guys, if you can take a screenshot of this. In one slide, it describes how you treat the thing. Emergency, elective, bleeding, resuscitation, vasopressin octreotide. Elective is non-specific beta blockers, propranolol or nadolol, endoscopic treatment, sclerotherapy, banding, and for if you have a stomach, those don't lend themselves to banding or sclerotherapy, and what you need to do is to use cyanoacrylate injection. Where features, particularly in elective, where features of risk, particularly red whale sign or signs of rectal hemorrhage, you go in for banding. Now the world has moved away from sclerotherapy because there's plenty of peri-esophageal fibrosis if you go for sclerotherapy. If it fails, and that was the Baveno 2 consensus, that's a single episode of rebleed, requiring 2 units of PRBC or more in 24 hours, systolic blood pressure less than 100, postural change more than 20 millimeter, PR 100 beats per minute, can go in for a balloon tamponade. And during one of my presentations, I used to say, don't use balloon tamponade. And one of my youngsters, one of you chaps said, so we don't have anything else in a periphery. And I stand completely correct. So you need to talk about balloon tamponade. So Ramanoj, you also made that point, didn't you? That peripheral centers don't have access to, state-of-art endoscopy. So balloon tamponade might be the only way you can get your patients to survive till they reach the next center where you can then do interventional radiology to the kids. We used to have 2 S's, but now it's 1 S, tips. And surgery, you can do a non-shunt or a shunt or an orthopedic liver transplant, particularly if you have a child C or a MELD 15 plus born, or a shunt in an elective or an orthopedic liver transplant for a child C or MELD C. Right. Ramanuj, that's fine. I'll stop sharing.
Okay.
Ramanuj, you can go ahead.
So I think we can start.
Guys, just put your questions out in the chat and I'll be around. I'll just answer the questions. Okay.
Okay. Hello.
Yeah, Ramanuj, you're audible. So you want to share your screen and go ahead?
Right. I'd like to start now.
I'll just make my mute myself.
Okay. Very good evening, everyone. Is the screen visible and am I audible?
Yes, sir.
Okay.
Yes, sir.
So,
Ramanuj, wait a minute. Can I just say something?
yeah, please.
Yeah, just give me a minute. Regarding the OSCE session on 12, it is going to be recorded OSCE from the previous OSCE days sessions, and it's going to start at 10 a.m. and it's going to finish at around 8 p.m. And post at 8 p.m., whatever questions you might be having, especially for the new people who are in, we'll have one of our professors from 8 to 9 who can answer all these questions. So remember, it starts at 10 a.m. and it'll finish at 8 p.m. Right? All yours.
Hello. Okay. So, very good evening, everyone. We start.
Yeah,
with
all yours. Yeah.
Okay. Thank you. We start with the second lot of OSCEs. And in this one, what I will do is that I will show you the questions, and then after you have written them on a white sheet of paper, then we will discuss about them as we go through. Now, with the modern pattern of this changing examination patterns, please remember that particularly for the national board examinations that will be held across various centers. Please remember that OSCEs will be one among the most important topics to discuss about in all surgical exit examinations. And in the future, again, for more or less many examinations, OSCE is the favored pattern. So the important point to talk about it is only one. Let us, I think that you have your pen and paper ready. Okay, so ladies and gentlemen, can we start now? Hello?
Yes, sir. Absolutely.
Right, let us start then. Okay, so whenever we are ready then, so the first question of the day will take around 10-15 minutes on the questions and the rest 1.5 hours on discussion. We are being shown a suture material, and the question is again very straightforward. Identify what is the specific use in groin hernia surgery. Identify what is the specific use in groin hernia surgery. So remember that the examiner has a very specific requirement for an answer. You are required to take around 1 to 2 minutes in writing the answer. So I hope that all of you are surgeons, it will be easy answer to write about in this one. Can I move on to the next one, please? Hello?
Yes, sir.
Can I move on to the next one? Identify the device. What is the use in gastric surgery? So this is a very specific question. Any form of a gastric surgery that you know, one answer or two answers, what is the use in a gastric surgery? So the question has been very focused answer only. So whatever you can write in a gastric surgery, what is the use? Remember that what has been uploaded on this instrument is the blue cartridge. I think that you can see that. Okay, can I move to the next one?
Yes, sir.
Yes, sir.
Here have been shown two pictures. Both of them are from the same device or an instrument. This is an easy one. Identify the device. What are the three salient steps in the safe use of this instrument? So, this has been an extremely common question for any surgical exit examination, starting from an MRCS to the MS to the DNB examinations. Every surgical resident has used this. Every surgical resident knows this. Can I move? Hello?
Yes, sir.
No. This is an interesting question. Remember that OSCEs, the reason about giving this question is for one simple reason. Because OSCEs could be a problem that has then the next or the two or the three questions may follow like this one. Or an OSCE could have been an individual set of topics. Okay, like Dr. Sanjay Debuxi was discussing, and I will be discussing, Dr. Vijay Sinha will be discussing. But OSCEs could have been a couple of questions that could be bunched up together, like this one. Identify the abdominal access site as shown. I think that I have the arrow pointing to one side. This is the right side of the abdomen. This is the left side of the abdomen. This is the cranial side of leg side of the patient. So you are being shown a site of abdominal access. What is the specific indication of use of this site for an abdominal access? Remember that all the answers are maximum one line. So the examiner is wanting you not to write an essay on this, just to write a single line. Okay, right. Now another very easy question. What is the specific use in laparoscopic surgery of a chemical agent? You are being shown a glutaraldehyde solution. So the question that you are being asked is a very simple one. What is the specific use? So the surgeon, so the examiner is wanting you to have a very focused answer again. And the second question is a little bit tougher one. What is the mechanism of action of use of this agent? So I think all of you have seen or used glutaraldehyde more or less every day for doing laparoscopic surgeries. What exactly is the specific use of laparoscopic surgeries of this chemical agent, and what is the mechanism of action of this use? Okay, can I move to the next one, please? Hello?
sir.
Another laparoscopic. Please see that these questions were thus in a series. So I took up this series because to impress upon you that questions can come in groups or cohorts. Okay. Identify the laparoscopic procedure. Question number 1. What are the complications of this laparoscopic procedure? Question number 3. What are the specific indications of such a procedure in a patient with an intestinal obstruction? So please understand that. Identify the laparoscopic procedure. What are the complications? What are the specific indications of such procedure in a patient with an intestinal obstruction? So the question has been, what is this procedure? One line. What are the complications? Maybe 2 or 3 words or lines, maybe. What are the specific indication? 1, 2, 3 points, maybe. Okay, can I move on? Can you move on now? Okay, let us proceed because we have a long way to go. Now, right, this question. Please see the image very carefully. A patient was planned for a right hemicolectomy for a bleeding colonic tumor. At laparotomy, you have been shown a finding. The question is, what is the specific condition that you have been shown in the picture? Number 2, what is the treatment outline in this patient? Number 3, what are the recent advances in local, that is peritoneal therapy for this patient? So all the questions have a very focused answer again, as I have said. No controversies onto these points. So the first question is, what is the specific pathology that has been shown? Second question is, what is the treatment outline for this patient? Third question, what is the recent advances in the local or peritoneal therapy? Okay, I think time's up, guys, and we move to the next question. Can I move to the next one?
Yes.
Okay. Now, simple one. You have been shown 2 images. One is that of a contrast image of the GI tract. Another one is a colonoscopic picture. First sub-question says that identify the pathology in a patient who presented with a bleeding per rectum. Question B of the same question is that identify the long-term complications of the disease. So there are 2 parts of the question. Identify the disease in which the patient presented with a bleeding per rectum. And number 2, identify the long-term complications of the disease. So that means again, time is very limited and your answer should have been very focused on to what is what. Okay. Hello?
Yes, sir.
Okay, right. Now, identify the surgical procedure. You are being shown a picture. Identify the surgical procedure. What are the complications of this surgical procedure? Now, this is an advanced level question. Until and unless you have seen such operations done or you have understood the rationale and the logic of such operations, it will be particularly difficult to talk about the complications. Because These complications are not that frequently seen until and unless you have had your GI rotations or you have seen a particular operation being done. Can I proceed?
Yes.
Okay. Now this is something that you said, okay, now he has come down to the appendix. Simple question. I am showing you a picture of an open appendicectomy. I think all of you have appreciated that even before I started reading. But I am going to show you, and I am showing you in the picture, a less common, mind you, this is a less common, uncommon surgical pathology of the appendix. The question are, what is the investigation of choice? Number two, what are the complications associated with the pathology? Please remember the questions are very, very straight and focused. What is the investigation of choice? Number two, what are the complications associated with this pathology? Hello? Now, this looks like a Mickey Mouse, isn't it? So, for all of you, I will draw the Mickey Mouse. Okay. Mickey Mouse is smiling at you. Now, the question is not about the Mickey Mouse. The question is about what is the pathology that has been shown. Number two, this is an intravenous urogram. So, you are going to see the cystogram phase of the intravenous urogram. Mention the two complications of this problem.
The next question.
Now, this one is something that I want you to look into very closely. What is the diagnosis? What is the pathology? What is the recording that has been shown? What is the recording that has been shown? So please see that. What is the recording that has been shown? Number two is that if a patient has a benign hypertrophy or hyperplasia of prostate, whatever is the word that you would like to say, the question is, what are the specific findings in a patient of this record. This is a very easy one. My lot of questions are always very simple, and you are laughing. Oh my God, this is the next most simple one.
Next.
Done? Wow, that's great. Simple question again. Diagnosis.
Next.
Indications of surgery.
Next.
Next. Wow, that's great. Great then. Done.
Next, sir.
Okay. The last question of the lot looks like an undergraduate question. Done.
Yes, sir.
Good. So these are the easy lot of questions I felt. Okay. So what did you guys feel? It was an easy one. Hello. Hello.
Yes, sir.
Yes, sir.
Okay. So it was so easy. Now everyone was smiling, sir. It was so easy. Right. Okay. Right. So let us
It will be
start
known
then.
after the discussion, sir.
Oh, it will be known after the discussion. Very diplomatic answer. So let us start from, should we start from question number 1 or question number 15? Which one?
Number 1, sir.
Okay, question number 1. We start with the easier ones. Then we go to the difficult ones. First of all, what is the, now please remember that if you are thinking this is a very easy lot, well, this will be always the mix in an examination. Some will be easier, some will not be so much easier. Number 2 is that whatever you are thinking is the answer in an easy lot, may not be that one. Now to start with this one. Identify the non-absorbable suture material. What do you think is the answer?
Proline, sir.
Very good. So this is not proline. This is called as polypropylene.
Polypropylene.
Okay, proline is a trade name, so do not try to use that. So it is polypropylene. Now, what are the technical properties of a polypropylene that make it a choice of suture in a hernia surgery?
It is non-absorbable.
Okay. Non-absorbable. Well. I am not very sure of that answer in hernia surgery, because nowadays even the laparoscopic tackers that we use have become delayed absorbable. Okay. Number 2.
Monofilament.
Very good. So what is the advantage if it is a monofilament suture?
Less infections.
Less chance of infections.
Modern days we use a term called as biofilm, and the bacteria cannot cling to this surface. Okay, so chances of infection, etc. less. Good. So this is a very, very important thing. Okay. Any other properties of polypropylene?
Non-braided.
Sir, monofilament is non-braided. Again, the same point. Okay. Next one. Very good. Is a tensile strength. I really appreciated that one. And particularly remember that the hernia is a weak area of the abdomen, and so it has been continuously exposed to the high tensile forces with a weak tissue to tackle that. So that means you need this to be with a high tensile strength. Okay, anything more?
Sir, what is the specific use in soil hernia surgery? Why should we write the step where we use the...
Sir, we are coming. So I am coming to this part of the question. Is polypropylene. So I asked you the question because I am going to come specifically in groin hernia surgery. Any other use? Because I am going to come from the use. Remember that the
Easily available.
Sir, in the days of Amazon and Flipkart now, everything is easily available. It is in order to online. Okay. To start with, remember that proline has an extreme high memory. What do you mean by the term memory of a suture?
It
Very
retains
good.
its original shape.
It retains its original, not only shape.
The length.
Shape is something that you can see. What is important thing is that it retains the important property of elasticity. And if you stretch this filament, and then again, it gets stretched up in a hernia surgery, it quickly returns back to the original length without any breakage or any micro fractures in the suture. This is the biggest disadvantage of use of a nylon suture for closure of the abdominal wall or in a hernia surgery. Hence, the advantage of polypropylene over a vicryl suture or a PDS suture or a nylon suture is the elasticity. So now tell me, in a hernia surgery, what is the important role or what is the specific role that you do this in a groin hernia surgery? What is the part of the groin hernia surgery that you use this suture for?
Anatomical repair.
Anatomical repair.
Strengthening of the fixation of mesh.
So, okay, if you have said herniorrhaphy, okay, I am happy with the term. That means if you have said strengthening of the posterior wall by all the techniques of herniorrhaphy, okay, I should be happy. Number 2, someone said about fixation of the mesh, and I am very happy with that. Because in this modern era, I do not know how many of you have done herniorrhaphy, but definitely I will be more happy if you say the fixation of the mesh in a groin hernia surgery. So let us quickly revise. This is an undergraduate question, that this is the symphysis pubis, pubic tubercle, anterior superior iliac spine. This is the rectus sheath, and this one is the arched fibers of the inguinal ligament. So let us quickly have this one described. So doctors, what is exactly the site of fixation of the mesh? So this is, ladies and gentlemen, the mesh in front of you. Okay. So all of you have done this operation many times. You know what is the thing. What are the points that you use to fix the mesh?
Sir,
Sir, initially we start with the inguinal ligament.
No, sir. The first stage should be the rectus sheath, sir. The medial side and the rectus sheath, sir.
Okay, right.
Medial bottom,
Right.
lateral bottom.
Now that means very good. That means see that how many for the operation that always has the same end point. See how many opinions are differing. Okay. So if you read guidelines like the NICE guidelines, which are the British guidelines, remember that the important part of these guidelines is understanding that one of the sutures has to be with the rectus sheath. One of the sutures has to be at least with the arch, if required to. Then one of the sutures takes in the tissue around the periosteum of the pubis, and the inferior margin is usually with the iliopubic tract. Okay, so this is with the iliopubic tract, and you go on fixation of this with the iliopubic tract. And so this, please remember, is technically the NICE guidelines to go about. So that means the NICE guidelines are very clear. And then finally, after you have done the fixation, you should split the mesh. And then after you have done a splitting of the mesh, you allow the spermatic cord to come through. And then thereafter, you go for something called as a fish tailing. That means this thing goes there and this thing goes there. And at the end of the day, there is a last stitch that is given. So, yeah.
Please, sir. So the first stitch, when asked, will be at the rectus sheath, not at the periosteum of the tubercle.
See, sir, no one is asking you the first stitch, sir, because
Sir, in Viva, sir, not here. In Viva, if they ask.
in Viva, sir, it depends upon your examiner's preference. Like, if you ask me, my personal preference is to start with the stitch near the pubic periosteum, that is near the pubic tubercle. I continue with the stitch on the inferior or the inguinal ligament or the iliopubic tract. That is a continuous suture in the picture that I have shown you. And then thereafter, I give the rectus sheath and then the superior margin, ultimately the fishtailing. But again, sir, as I have told you, this is a part that is much more of a personal variation, that which stitch you are going to start first. But see, all of us have agreed on one point, that whatever it is usually the medial side which needs a fixation first, rather than the superior or the inferior side. I hope we all agree on this point.
Yes, sir.
Yes, okay. Right. So this is the specific use in a groin hernia surgery, is fixation of the major these points. Right enough. So this was a very easy one. Second question. Identify the device. What is this device?
Linear stapler.
Linear GI stapler.
Very good. See, this is the reason we will need discussions in this forum. Linear, everyone has said. GIA means gastrointestinal approximating stapler, some of you have said. But this is in reality
Cutting.
exactly better called as a linear cutter, or if you ask me the technical name that I will be saying this in an examination written, or that means OSCE and the Viva, this is a linear cutting stapler used for gastrointestinal anastomosis or approximation, particularly a side-to-side anastomosis. So please remember that the technical name for this is not a linear stapler. A linear stapler only staples. You have to cut with a knife or a scissors. A linear cutter has in its own a ready-made knife assembly. Now, while the bowel is in between, the knife moves like this and cuts across. If there are the two lumens of the bowel, what the knife does is that the knife cuts across the two lumens and makes a side-to-side anastomosis. So this is what is exactly a linear cutting stapler. Now, as you have said, there is a blue cartridge. I cannot comment upon the length. I do not know that the length was visible or not. No, I am not very sure about the length of this one. But what is important to this is that what is the use in gastric surgery that you know of? This is the easy question. What is the use in
resection of gut margins before anastomosis?
Sir, in gastric surgery, can you name an operation in which it is used?
Gastrojejenostomy.
Okay.
Sleeve gastrectomies. Sleeve gastrectomies.
Wow. One by one. So let us start with the first one. It is used in gastrojejenostomy. Okay, I am happy with this.
Sleeve gastrectomy.
Sleeve gastrectomy. Okay, I should be happy with this. But wait. What is the color of the cartridge? Come on, man. What is the color of the cartridge?
The blue. Green for the stomach.
Exactly. Wait. This is the blue, na? So if this is a blue cartridge, please remember that what is the companies will differ. I know that you can have Ethicon, you can have Covidian, Medtronic, etc. What is the close staple height of a blue cartridge? Usually
1.5 for blue and 2 for green.
Very good. So for the green ones, it is 2, more or less. Now that will be going by a couple of millimeters more or less, but it is on an average 1.4 for a blue, 2 for this one. Now that means very straightforward. If the stomach is thickened, do you think you will be using a blue or a green? Green. But I am showing you a blue one. So if you are doing a gastrojejenostomy, okay, I will be happy if you have done it particularly in a malignancy where the stomach is not that distended, then I can use this. But if this is a benign gastric outlet obstruction with a long-term thickened stomach, then remember that it is preferable to use a green rather than blue. But the main question is not benign or malignant. But the main question is in a sleeve gastrectomy, do you know what is the main problem in obese and the stomach in an obese? The stomach in an obese is thick, much thicker. And your green or blue is not exactly the color of the stapler that you are going to use. So what is the color of the stapler that we use in them? Gold. Yes, exactly. Bronze or golden color of stapler. They target about 2.5 millimeters to about 3 millimeter will be the close staple heights in that one. So this is not an ideal one for this one. So, okay, if you have said sleeve gastrectomy, you will not be very happy with it, but still I will be giving. Any other things that are done in a distal gastrectomy? Any other use of this one? I expected this to be the first answer.
Division of pylorus.
Division of pylorus or anything more specific. In a distal gastrectomy, do you divide the pylorus, sir? Okay, come on, man. We are talking distal. See, there is nothing called a subtotal gastrectomy in the year 2021. These are not standard terms anymore, please. So don't use this. Near total gastrectomy, subtotal gastrectomy, 2.5 gastrectomies. Those are all old. If you are doing the half of the stomach, this is called as distal half or distal gastrectomy. Where is your transaction line distally? If there is a cancer in the antrum, where is your transaction line distally?
5 centimeters.
4 centimeters from the pylorus.
Very good. Now, remember that cancers can spread upwards. Okay. So this margin is 6 centimeter, not 5, please. But the distal margin, if this is the pylorus, someone has said that, and I really liked it, is usually 2.5 centimeter from the pylorus. Now, what is the length of the first part of the duodenum? Is 2.5 centimeter. Okay. So that means your stapler is going to cut through the first part of the duodenum. And you are going to get what thing is a part of this one? So what is this part that I have drawn? What is this one? This is the duodenum stump. Very good. Not second part, sir, not second part. Duodenal stump is not a second part. Remember that. Duodenal stump is a part of the first part. The first part length is 5 centimeter. You have taken away the 2.5 with the specimen, the 2.5 remains with you. Do not take your stapler to the second part. That is not a very happy option. Second part is not a very good area to close. Okay. So how do you close the duodenal stump? Very simple, man. You use this stapler and then this stapler fires a double row of cartridge. You can again insert another layer of a reinforcing sutures over this. Like this is my practice to do that, but again there are no evidences. If you have done a good staple line with a blue cartridge, this is good enough to close the duodenal stump. So if I ask you in a gastric surgery, in a distal gastrectomy or in a gastrectomy, like total gastrectomy, closure of the duodenal stump is done very, very well by this one. If you are using it for gastrojejunostomy, okay, I'm happy with it. But provided the thickness of the stomach is not that great, sleeve gastrectomy, well, I'll not be very happy. So these are the things. Now someone said cystogastrostomy. I heard that term, cystogastrostomy. What do you exactly mean by this term? Because if you have any doubts, so let us be clear in these doubts now. Someone said cystogastrostomy. What is cystogastrostomy? Hello?
Pseudocyst of pancreas.
Pseudocyst of pancreas. Very good.
Most of the stomach and the
So, pseudocyst of pancreas, even if you are doing it laparoscopically or open, whatever way you have done it, this is the anterior gastrotomy and this is the opening in the posterior wall. And this is a cyst that has opened into the stomach. Tell me, ladies and gentlemen, how are you going to fire the stapler to do a linear cutter to do a cystogastrostomy? I am at loss of words. I do not know of any technique in which I will be doing that.
No, it's an action.
No, forget hands tune. Even if you are doing a laparoscopic procedure with a laparoscopic endo-GIA. See, the main thing in a cystogastrostomy is that you need to remove a disc. It is not a linear cut, please. A disc of tissue has to come out. The disc of tissue contains the stomach part and the disc of tissue contains the cyst wall. So that means whatever you do, you need an energy source or a knife or a scissors, whatever it is, to cut out that disc. And after you have had a cutout of the disc, you are left up with a big hole in the posterior wall of the stomach and there is a big hole in the cyst. I feel there is no other option, even if you are doing it laparoscopically, rather than take an intracorporeal suture and give at least 4 sutures at 4 angles. If you are using an endo-GIA to fire that, well, I do not think that is a very safe option, sir, because the cutting line then will be a linear line, which will be very easily closed. This is not the main principle of the operation. So please do not say this is used in a cystogastrostomy. Okay? Now, come to this one. What is this instrument? Everyone knows this. Even an undergraduate knows this now.
Very necessary.
Spelling? Come on, man. Everyone just silent.
V-E-R-E-S-S.
V-E-R-E?
Yes, yes.
1 S or 2 S's?
Yes,
2 S. Like this.
Less.
How many E's?
R-E.
Oh.
P-E-E-R-E-S.
Double S, sir.
Oh my God. It went on to... Okay, so there were many E's and many S's. So the spelling is V-E-R-E.
V-E-R-E-S-S.
S-S. Please remember this one. Okay. So this is the spelling of the various middle. Okay. Who was the gentleman who invented this? Janos Veris. I know that Veris. Okay. What was his, or what type of physician or surgeon this chap was?
Physician.
And did this for doing an iatrogenic pneumothorax in the era where antitubercular drugs were not available. So people did iatrogenic pneumothorax in the 1920s. so that the lung would have collapsed, undergone a fibrosis, and then gradually it would have expanded, or to do an aspiration of the fluid from the pleural cavity without injuring the lung. So those are old times. Okay, nowadays we have moved much away from these things. Now, so what is important for doing is that identification is done. Now, I've been asked in a laparoscopy, what is the main use of this device? Single word.
Pneumoperitoneum.
To establish pneumoperitoneum
by a closed technique.
Very good. This is the answer that the examiner is wanting for. Pneumoperitoneum can be attained by a closed technique, that is use of a varies. Do you know of other techniques to attain a pneumoperitoneum?
Open techniques.
Open technique. What is that technique called?
Essence.
Spelling please. Spelling please. H-A-S-S-O-N. Good. Not Hanson, man. I know that you are a handsome man, but this is not Hanson. It is Hasson's Tokan. Okay. Now, any other technique? Open done. Very good. There's something called as direct trocar entry. Okay. And direct trocar entry, some of surgeons have interpreted it very wrongly. Without doing anything, just they pray to God and just put in the trocar. Now, God did not tell you to do like that. If it is a direct trocar, what is the special type of the trocar that is used in this one?
Optical trocar.
Very good. So this is called as an optical trocar. No. Again. See, blunt tip trocars are used maybe in an Hasson. If you are saying I have a blunt tip trocar and I'm just cutting the skin and pushing in the trocar, and God knows what is coming in the way of the blunt tip, that is an absolutely wrong thing that you are doing. That's it. This is to be condemned, and this is not the standard of care. If you are thinking about not doing the Hasson or the varies, you only have a third option. That is something called as an optical trocar, where every layer that you are cutting, that means an optical trocar, what it does is that the camera is there in the optical trocar, and the optical trocar has a folded knife. When it gets the resistance, it cuts through the tissue, and you know what you are cutting through the tissue. Oh, that doesn't make it immune from a bowel injury, because you will see the bowel getting cut. But again, the basic idea is that you can stop pushing the trocar when you feel there is a bowel in your field. So that is called as a direct trocar. And again, it's not a very well recognized technique. Majority of surgeons across the world will either be doing the open trocar, like if you have seen majority of European publications, they are more in favor of an open trocar. Whereas if you have seen American sites, then or bariatric people, they are more happy by doing a closed or a very single trocar. So this is all about these things. Now the question was not this. The question was, what are the things that tell you that there is a safe use of this one? So the first of this one is that what are the steps of putting in a varies? So let us quickly understand that. Now, for a right-handed surgeon, okay, which side does the surgeon stand? Let us have this. Okay, left side. Very good. This is the question number one. Question number two. After where is the skin incision made usually?
Infraumbilical or supraumbilical? Both done.
Okay. Now the conventional teaching was you could have done it through the umbilicus, because with one logic being the umbilicus has only the skin and the fascia, and then there is the peritoneal cavity. But again, people felt that no, umbilicus may be a cosmetic area, so it may be a difficult one. So people started doing subumbilical and supraumbilical, even transumbilical. So the question again got lost in the notion that the question is not about an umbilicus. Do you know what is the distance in a normal thin-built adult between the umbilicus and the abdominal aorta? Any idea?
1 centimeter.
5?
1 centimeter.
Okay. Not exactly. In a normal adult, remember the distance is always less than 1 centimeter. Depends upon how less fat he has. So that means if the patient now starts getting obese, you say, wow, man, he's so obese. Now, so he started getting obese. Please appreciate that the distance between the aorta and umbilicus is increasing. So much so that in a morbidly obese, the distance can be up to 5 centimeters. That means only 5 centimeters. If you are talking 5, that means only 5 centimeters. That means what is the direction in which you are holding or the Veress needle comes into the peritoneal cavity?
Towards the pelvis, sir.
That means very good. So that this is another secure. Yes. So in a thin built adult, please remember a 90 degree is not allowed. In an obese, you may do a 90 degree, but you are doing it at your own risk. 5 centimeters is too small a distance. Always remember that. Then, as you have very rightly said, it comes at a 45 degree. 45 degree angle to what? Towards the pelvis. Now, come on, when you are holding the Veress needle in your right hand, your left hand punches or holds about the lower abdominal paniculus of fat. It is 45 degree to the abdominal plane. Some people say to the sternum or to the patient's bed. And sorry, this angle becomes 45 degree. And you introduce it in that 45 degree. Now, after you have introduced the Veress, how many clicks do you hear? 2. Very good. 3. Not 3, certainly. Okay, what are the 2 clicks for?
Linea alba and surgical peritoneum.
Very good. Linea alba and the peritoneum. That means these clicks are 2. One is for the fascia or whatever you call that to be, linea alba. Another one is for the peritoneum. You should not have more than 2 because that means your structure is getting hit by something else. Now, if you are doing it through the rectus sheath, that becomes a problem about 2. Then you have this click, another click, and then the peritoneum. So maybe. But if I'm doing it through the umbilicus, I had 1 click and another click. So please be very clear in understanding that. Now, once you are in the peritoneal cavity, in a viva table with an instrument, examiners will ask you, hold the Veress needle. What is the technique of holding the Veress needle? One word, please.
Like a pen?
No.
A dart.
Like a dart. The grip is called as a dart holding grip. Okay? It is not like a pen. Surgeons like to take chances and you are holding it like a dart. After you have entered the peritoneal cavity, the Veress needle comes into now being straight. Why don't you wiggle the Veress needle or why don't you keep that 45 degree angulation is because now you are in the peritoneal cavity. Now if you can do that, the Veress needle can slide again. You do not need that slide. Once you are in the peritoneal cavity, you should make it again at a 90 degree because you know it is the blunt tip of the needle which is in the peritoneal cavity. So there is no damage that is done. What is the flow rate of carbon dioxide through the Veress needle?
2.
Maximum 2.5 liters per minute. Always remember that. So a trocar, it can be 10 to 15. So a Veress, it is 2.5 liters per minute. Now let us talk about, after you have entered the peritoneal cavity, you do not start the gas. What are the things that you do when you enter the peritoneal cavity? Or after?
Confirm, sir.
How do you confirm, sir? How do you confirm?
The Veress needle is in this
How do you
saline
confirm?
test.
Sir, water drop test.
Wait. This is the reason I told you. 3 saline steps. Step number 1. After you have put in the Veress needle in that. First step, no one does this, is aspirate with a 10 ml syringe that contains normal saline. This is the piston. This contains 10 ml of normal saline. Attach it to the Veress needle and aspirate. If aspirate contains blood, what do you understand by that? That means congratulations, you are now into the vena cava. Very good. This is the vena cava, man. Congrats. If it contains fecal matter or bile, what do you mean by this? That means you are in the bowel. In 99% of the cases, when you aspirate, nothing comes out. No air bubble. Please don't say that I aspirated and air bubble came out. That means you are in the colon. Nothing comes out. Nil. And then what you do is that step number 2, you push in 5 ml of the normal saline out of the 10 ml. Step number 3, you re-aspirate. how much will return if it is in the peritoneal cavity?
Nothing.
Nothing. But if it is in between the anterior and the posterior ductal sheath, how much will return? That means probably 1 ml will return or 0.5 ml will return. If there is a return fluid, that means your varice is not in a good place. You are not in the peritoneal cavity. So please understand that. You need to change the position of the varice. Hence the 2 clicks and 3 clicks story. So aspirate, push female and then re-aspirate. After you have done that, step number 4 is the hanging drop test. This is something that you know how to put in a normal saline, lift up the abdominal wall, the saline drop goes in. And after you have done that, then connect the insufflation tube. Then connect the insufflation tube. Okay. How do you know that the insufflation tube after connection or the varice is in the peritoneal cavity? What is the initial reading in the insufflator?
It is slowly.
What is the initial reading in the insufflator? That is a rise, sir. What is the initial reading?
0 to 5.
0 mm.
0. Also 0, man. Please remember -5 to +5. Okay. -5 to +5 because the normal peritoneal cavity is around 0, -2, -3, sometimes to +2, +3, but definitely not more than 5. And then how do you know that? Say for example, the varice is in a loaded colon with gas. You will have all these signs. Okay. But the only question is, how do you know that your insufflation is getting adequately done? I have had experiences of surgeons putting in the varice in the colon.
Sir, you
Then-
palpate the abdomen for resonance.
Very good. Sir, the important point is all the 4 quadrants of the abdomen are seen to rise equally. If it is colon, then what would have happened? One area, there had been an asymmetric dilatation. So please remember, if it is a peritoneal cavity, all the 4 quadrants are known to rise equally. And thereafter, you see for what signs are obliteration of the liver dullness. Okay? So this completes the story. So these are the 3 salient steps. That means aspirate. Number 2, re-aspirate. Number 3, hanging drop. Number 4, connect the tube and see the insufflation pressure. So these are the points to talk about in a various needle. Okay? So I can say more things in a various needle. So these are all the things to talk about. This is a reusable various needle. What is the usual length of a various needle that you use? Sir, do you know what are the sizes in which a reusable various is usually available? Very good. So the usual sizes that are available are 8 centimeter. In which operation is it used? Come on, man. Which operation did you use that? Sir, I used this during pediatric laparoscopy. Okay, dekho, I have drawn the bacha for you, the kid for you. So this is a pediatric laparoscopy. Or I can have a 10 centimeter or a 12 centimeter varice. This is the standard varice and is used in an adult. If it is 20 centimeter, then very good. That is a bariatric varice. Okay. So these are the standard questions. What is this thing called as?
Lock, liver lock.
Valve. Very good. Not valve, sir. This is called as a lower lock. This is a standard universal attachment. Okay. Right. So we have completed this part. Some people
Sir,
say
is
that
checking the spring of the varice a part of this safe insertion?
yes, absolutely. I was going to come to that. Before you have started even taking the varice, before you have started even handling the varice on the patient, it is always mandatory to see whether the spring mechanism of the varice is working or not. So if you are writing out of the 3 salient steps, the spring mechanism, yes, I will be giving full marks for this one also. Okay. So definitely depends upon what kind of answer that the examiner wants. But as you can see, there are multiple safety checks on the varies for insufflation in this. Okay, right. So more or less, we have completed a major part of the story that is done. Now, the important things are to ask about is that what are the incidences of a bowel injury? What are the incidences of a bowel injury in a various dental? Hello? Now, say for example, there is a bowel injury. Okay, open versus varies. Okay, what is the chance of a vascular injury? And what is the chance of a combined injury? Right? Okay, please. What is the chance of a bowel injury in an open? Now, majority of the series that are there are very old, maybe around 2000 publications around the year 2000. So that's pretty old, but still, remember that in open, the chances of a bowel injury are paradoxically more. Okay, so that means that per 1000 cases, they got around one case of an open injury. In an varies, remember that the bowel injury was a little less of 0.4, whereas vascular injury in an open is 0. In a varies, the vascular injury is 0.4. A combined injury in an open is about 1. And in a varies, the combined injury is 0.4 plus 0.4 is equal to 0.8. So please remember these statistics. This was done by a gentleman called as Molloy et al. So this was a big series that we always quote for the last 20 years. There has been other series, but this one is a very favorite series to talk about. Okay. So we have completed, we have taken a long time on this one. Question number 4, please. What is this abdominal axis site that I have shown?
The Palmer's point. Palmer's point.
Very good. So this is the Palmer's point. Good one. Now, when I talked about the Palmer's point, this gentleman called Raoul Palmer was a gynecologist, was a French gynecologist, and he thought about this point. What exactly are the dimensions of this point, or how do you find this point? How to find the point?
2 fingerprints below the left subcostal margin in the mid clavicle.
Okay. And now, sir, again, sir, you cannot see the rectus now. You cannot get to see the rectus, sir. You may get to, but again, so the first of all, as you have very rightly said, mid-clavicular line is the fixed anatomy. Sir, rather than talk to fingers, I will be more happy if you mark it as a distance of 3 centimeter. So the classical description was a 3 centimeter mark over the, or in contrast to this area. So this is what was the usual anatomy of a Palmer's point. Now, in what indication is the access done through the Palmer's point?
Umbilical hernia.
Okay, umbilical hernia.
Well,
Right.
the patient
And
has a previous scar in the midline.
Very good.
patient, sir.
Very good. Particularly remember that infraumbilical midline incisions like this, or where you are expecting a dense infraumbilical adhesions, then doing a pneumoperitoneum by open or closed through the umbilicus or around the umbilicus will be a difficult option. Hence, that is the reason Palmer's point is used if you expect or contemplate a very dense infraumbilical adhesion of bowel, etc. What is the contraindication of not using a Palmer's point? Or what is the contraindication of using a Palmer's point? Or when not using a Palmer's point?
Massive splenomegaly.
Splenomegaly. Excellent. So, sir, there are 2 contraindications, as you can see in the picture. Either the spleen is big or the stomach is distended. So that means before you put in the Palmer's point title, it is always important to put in a Ryle's tube, aspirate the stomach, and then make the stomach less or decrease or collapse in size. But if you are doing it for a gastric outlet obstruction, like a truncal vagotomy, gastric duodenostomy, then Palmer's point is not at all a very good option because you are going to find the big distended stomach below your anterior abdominal wall. Okay? Have I made clear on this point?
Yes, sir.
Hello? Right. Chalo. Now this thing is again,
Yes.
right. What is the specific use of this agent?
The sterilization of
So
laparoscopy.
stabilization of the laparoscope
Wait.
in between the two lap disinfectants.
Okay. Now I cannot take a vote in front of you guys, but if I did take a vote, how many of you had voted for a sterilization? How many of you will vote for a disinfection? Oh, technically I will be say high level disinfection. Which one do you think is done by this glutaraldehyde or Sidex?
Disinfection, sir.
Not sterilization? Okay.
The sterilization
Exactly. Very good. And I really appreciated that answer. If I am going to use one single answer, then what is that answer, sir? Sterilization or disinfection?
the disinfection between surgeries.
Exactly. And anything to add before the word disinfection? Anything to add before the word disinfection? It is a high level disinfection. That means bacteria are killed. Okay, viruses are killed. Prions are killed. What is not killed?
Spores.
Spores are not killed. Very good. Okay, so spores are okay. But the contact time for a high level disinfection is at least
20 minutes.
20 minutes. Wait. The job has not ended. Okay. At a pH of 8. Please remember that. At a dilution of at least 2%. So, even if you are using Sidex again tomorrow for an operation, please remember that if the minute you dip in that instrument in the Sidex or whatever you call that to be, it is mandatory that you see the concentration of the glutaraldehyde, which if you are diluting that, and if the pH of this falls less than 8, please remember that the disinfection quality is going to deteriorate and you are going to have infections. Number 2 is that disinfection with this is more or less high quality, but this is also an irritant to the skin. So when you are taking out the instrument from a glutaraldehyde, it is important that you wash the instrument with normal saline which has been sterilized. Please remember that. Normal saline which has been sterilized. Okay? Some people used distilled water which has been sterilized. That is another point. But these are all the things to know about. Now, can it do a sterilization? The answer is yes, it can do. But provided the contact time now becomes 24 hours at least. Again, with a pH of 8 and with a concentration of 2%. Am I clear up to this point? Okay. What is the mechanism of action of this one? This is a tough one. The mechanism of action is the same as formaldehyde. And remember that what formaldehyde does is that it goes in for alkylating or alkylation of proteins and nucleic acid. That means it is basically the DNA which is damaged of the microbes and they cannot act upon this. So this is all about things that you are required to know. Okay? Right. Chalo, okay. Now, identify this laparoscopic procedure. What is this laparoscopic procedure? Very good. So, adhesiolysis is the answer. And you know about this one. I'm very happy with this. Okay. What are the common complications of this addition of this procedure?
Inadvertent enterotomy.
Okay, definitely inadvertent enterotomy. Okay, and definitely, as you have said, other viscera like again bowel and bladder are the two most common organs injured. Particularly if you are working in the lower abdomen, a group of publications say that bladder is the most common organ injured rather than the bowel. Particularly if you are working with a hernia surgeon who is doing a redo hernia in the lower abdomen, they are always very, very skeptical about not only the bowel but the bladder. So enterotomies and bladder injuries are the very common problems. Now the question was, the patient came with an intestinal obstruction. What are the indications of doing this procedure?
There is no peritonitis.
Very good. So, sir, that is a contraindication. What is the indication?
Failure of conservative.
Failure of conservative management. That means, tell me one diagnosis. Diagnostic laparoscopy. Well, that is the reason I exactly gave this question to you. The next day, let me see how many of you put in a laparoscope in a patient who has such loops of distended bowel in the whole abdomen. Tell me, give an honest confession. How many of you will be able to find out, all of you have done laparotomies for distended bowels in the abdomen. How many of you will be able to find out in the distended bowel loops with a laparoscope, what is the exact cause of obstruction? Believe me, it becomes a technically very difficult job.
In case of diagnostic dilemma, sir.
Diagnostic dilemma, sir. You have to CT.
Sir, I have seen this OT go on for 8 hours at some place.
Exactly. That is the point, sir, to make. And that is the reason I took up this question. Sir, tell me, is it really worth doing this operation for 8 hours? Absolutely not.
And there were 7 enterotomies done.
And there were 7 enterotomies done. Very nicely said. This is the reason, sir, a surgeon should determine at what point of time he should convert that and go in for a simple laparotomy, and that would have prevented lesser number of enterotomies. The operation time for the patient would have become much less. This is the reason, sir, I took up this question, because a laparoscopy in an intestinal obstruction has a specific set of indication. The number one is a subacute bowel obstruction. Remember that. And the subacute bowel obstruction is because the bowel loops are now collapsed. Now, how did you make the bowel loops collapse? Either by putting in a nasogastric tube, giving enemas, the bowel loops are collapsed. But remember that when the bowel loops are collapsed, at least some amount of bowel loops which are proximal to the obstruction, they are collapsed. That is going to make your job easier to handle those intestines. Then, after that is, number 2 is that, as you have very rightly said, is that whenever you have a diagnostic dilemma, now what particular etiology do you think you have a diagnostic dilemma? Tell me one particular etiology that you have a diagnostic. Pardon, please?
Sir, a band causing obstruction.
Tuberculosis.
Very good, sir. A band causing obstruction. What type of band?
Congenital.
Very good. A congenital band, like as in children with a Meckel's band, is a very right answer. Lad's band, yes, is a very good answer. But again, as the gentleman has very rightly said, Lad's band are not one but multiple, and it will really take you a big skill to do that operation. Number 3, what is more important is, when you expect that band addition to be due to some diseases where, like tuberculosis, where you remember that you need to take a peritoneal biopsy. I think someone of you would have commented upon
Peritoneal depositions.
exactly. Don't you say the stalactites and the stalagmites like thing? Okay. One of these etiologies is tuberculosis. What is the rare other etiology of these white nodules in a post-operative abdomen?
That's
Adenomyosis.
Have you heard about this peritonitis? The next time you are wearing a gloves, have you seen that powder on our gloves? So what does it produce? It produces a form of peritonitis called as talc. Well, if you are talking about tumor, well, I'm also happy. Appreciate that all these white dots go by the letter T. TB, talc, and a tumor. So what is the beauty about a laparoscope is that under these doubtful circumstances, which are not picked up on a CT scan, you can go in for these ones. So if I am asking you the question, what is the specific indication? Subacute bowel obstructions with the bowel being collapsed. Number 2, a diagnostic dilemma with a band obstruction, particularly with TB or with a talc peritonitis, or in a condition where you need to take a peritoneal biopsy. Okay, so these are the indications of doing this procedure.
Sir, what is that instrument that you have used, sir? It is, can you just show?
The instrument probably is, sir, this is an instrument that is a composite one. It has combined, as you can see, a non-tooth grasper and a scissors along with it.
Right, sir.
So this is a very, again, a versatile instrument that people will use. That. So now, this question, again, something to do with the peritoneum. Okay, what is the specific condition that is shown? Pseudomyxoma. Sir, bleeding colonic tumor, man.
Sir, peritoneal deposits, omental deposits.
Okay,
Omental
sir,
deposits.
I will like a very simple answer.
Peritoneal carcinoma, sir.
Very good. Peritoneal carcinomatosis. The single word that describes all Seviston is peritoneal carcinomatosis. You can say omentum, you can say serosa, whatever you like. This is peritoneal carcinomatosis. What is the treatment outline in this patient? What are you going to do in this patient? I think. Come on, man. This patient.
Palliative chemotherapy.
This patient is bleeding now. What is the procedure that you are going to do?
Colonic dissection.
Absolutely. So the step number 1 is
dissection.
Bending. Oh man, sir, you have done a laparotomy. The patient is on the table. The patient is bleeding from a tumor, probably on the right side of the colon. So what is the only operation to be done?
Resection.
Sir, I'm going to go for a palliative, right?
Ligation.
Right hemicolectomy, no ligation, sir. What is the palliation that you do? What is the palliation that you do?
Colectomy.
Exactly. Now, that type of a palliative colectomy does not take care of the lymph nodes. That is because if there is a tumor in the colon that is bleeding, the only thing that you need to do is that you need to just ligate the vessels, take out the specimen, and after that you have this ileum and the transverse colon. You may join, you may not join, that is up to you. Those are different perspectives. But to stop the bleeding in this patient, the main thing to be done is forget about those peritoneal meds. Please do the palliative colectomy first, save the life of the patient. Then preferably do an anastomosis so that you can allow the patient to start on. Thereafter with an adjuvant chemotherapy. So this is the standard line of management, sir. So the standard treatment of this is that palliative right hemicolectomy with an adjuvant chemotherapy. What kind of chemotherapy are you going to use in this patient? What regime of chemotherapy would you like to use in this patient?
Folfox.
Very good. Folfox or folfirix? Okay. So please remember this one. So this is the standard line of management. Now the question has been asked is, what is the recent advance in local peritoneal therapy in this patient? What is the answer to this one?
HIPEC.
This is HIPEC. But before you do the HIPEC, what is the score that is used for assessment?
Sugar-Becker index, sir. Sugar-Becker index.
Very good. Again, sir, Sugar-Becker index is a better name, but what is the name of that score? That score is called as PCI index. Okay. What is the PCI index in a colonic malignancy over which you are not going to give HIPEC?
20, sir. 20.
In a colon, to the best of my knowledge, it is 12. In a other parts or pseudomyxoma, it is 20. In a stomach, it becomes 8. Okay, right. So this completes your HIPEC and this one. This is a very straightforward question. What is the pathology in this patient?
So ulcerative colitis.
Sir, for palliative purpose, sir, excuse me,
Yes.
sir. Sir, for the palliative colectomy, sir, should we remove the lymph nodes or not, sir?
No, sir. Sir, palliative resection is only done to improve the quality of life. It is only for improving the quality of life and to making the patient alive. That's it. If the patient had a perforation, just resect that part of the bowel. If the patient had a bleeding cancer, just resect that part of the bowel. Now, if you have asked me a tough one, if the disease is oligometastatic, now oligometastatic means that say for example, this is not an oligometastatic disease. There are so many deposits that you cannot count them. But say for example, a patient has only 2 liver metastases. The rest of the abdomen is clean. Then the question is, for the liver, will you like to go in for a surgery? Yes, maybe.
Yes, sir.
Then if you are doing a surgery for the liver, then what is the first requisite for surgery of the liver? There should be an R0. Sir, that is the other part of the story. Even before you calculate the FLR, what is the first consideration in any colonic tumor, right or left?
Primary should be removed.
Exactly. What do you mean by primary should be removed?
Resectable primary.
Sir, R0. That means the tumor and the nodes. Isn't it?
Yes, sir.
That is the time where a palliative colectomy has to take in a lymph node. But in this patient that you can see in the picture, there is so much amount of serosal peritoneal deposit that you cannot take this thing out, sir. There is only HIPEC that can come to your help. So for this patient with a bleeding colonic tumor, there is only one target. I need to take that part of the colon out. Bas. Chalo. This patient, this is an ulcerative colitis. This is an ulcerative colitis, good one. As you can see the ulcers, etc. What are these dots in this? Or what are these ones?
Pseudopolyps.
Very good. What is the cancer chance from these polyps? What is the cancer chance in these polyps?
After 10 years, 1% every year.
No, sir, absolutely not. This is the trick in the question. In an ulcerative colitis, please remember, what does a pseudopolyp indicate? Pseudopolyp indicates the normal epithelium which is trying to grow. Remember that. What is bad is this epithelium that is in between the polyps. What does this epithelium in between the polyp denote? This epithelium denotes the scarred epithelium. The disease activity is in this. The pseudopolyps are like the grass that is growing in the fields. So they are the normal mucosa which is trying to come back. But the scarred epithelium in between the pseudopolyp has something called as DALM. What is the full form?
Dysplasia associated lesion.
Exactly, dysplasia associated lesions of the mucosa. So whenever you are doing a colonoscopy or the colonoscopist is doing that, they are going to see not the pseudopolyp. They know that pseudopolyps are nothing except that they will bleed. They are more interested in seeing what is the scar tissue. Do I see any kind of a dysplastic epithelium or any kind of a neovascularization, anything in the scar area? What are the long-term complications of an ulcerative colitis? Just 2.
Adenocarcinoma.
Number 1 is that colonic cancer. Okay, very good. Number 2. Any other long-term complications? Much more commoner than an adenocarcinoma?
Toxic strictures.
Very good. Is a stricture.
Toxic megacolon.
Toxic megacolon is a very good answer. Okay, so we have 3 complications: toxic megacolon, stricture, and a colonic cancer. Good one. So this completes the discussion. Come to this one. Now talk about this one, ladies and gentlemen. What is this one?
Sir, what is the chance of malignancy?
Malignancy, someone has said that. As I have said.
Is it 5%, sir? That is normal.
Technically should be 0. Now technically should be 0 doesn't mean that after 5 to 10 years, the time where cancer starts, the epithelium as such is undergoing a change. So 0 should not be a good word, but the risk of cancer arising from the pseudopolyp is low. Okay, have I made you understand this point? Right. Now let us talk about this one, please. What is the surgical procedure?
Ileoanal anastomosis. Total
Ileoanal pouch. Ileoanal anastomosis.
Okay, so it is ileoanal pouch anastomosis, also called, as you have said, a J pouch. Okay, now this type of an operation is also, people used to call this as a restorative proctocolectomy, can be done after an ulcerative colitis and a surgery for a FAP. Right. Sir, allow a few words around what are the complications of this? Okay, pouchitis. Right. Now, good one. So let us have things in pouch. So I have had time now to discuss 5 minutes on pouch. Particularly those who are listening to this lecture, a few things in pouch. Remember that. Okay. Now, what is important is that after audios kindly mute your audio. After the pouch is created, the patient has on an average of 4 to 8 motions per day. Thus, the patient is always kept on a dietary modifications like absence of refined carbohydrate, and it is in the first year that the patient will need loperamide. Right. Number 2 is that more is the duration of the pouch. Remember that more is the duration of the pouch, the more is the chance of critical incontinence that arises due to the pouch. So we should talk about the complications that arises from the pouch, because this has been the complications. I like to talk about diet modification. What did you say? Diet as avoidance of refined carbohydrates. Okay, right. Now, what are the complications? The complications of the pouch would have been surgical. Can you mention any surgical complications immediate to the creation of the pouch? Yes, sir. Particularly in Crohn's disease, yes, in Crohn's, people may not consider doing a pouch. Volvulus, because if you have a long redundant, not seen in a J pouch. Stenosis of the pouch, because of the anastomotic narrowing. Okay. Now, if one side is surgical, another side is, that means the disease that you have done for is coming back to the pouch. What is the inflammation of the pouch called as? Pouchitis. Very good. So that brings us to an MCQ. What is cophitis? What is cophitis? Okay, we'll come to that again. So remember the question. And please remember that pouchitis is usually manifested by what group of symptoms? The pouchitis is manifested by bloody stools, increased frequency of stools, tenesmus, incontinence, okay, weight loss. So these are usually the group of things, and the last of the complications can be a cancer, also better called pouch cancer. So please remember that if you are asked about in theory also, what is exactly the standard things to remember in a pouch. Now, questions that are asked again are very state factor. What are the particular predisposition, or what are the things in which pouchitis, that means an inflammation of this pouch like the disease ulcerative colitis, is known to occur more, or which group of patients have a more risk of having an pouchitis than the other people? Number one is that if the patient has an extensive ulcerative colitis, like this picture that I have shown you. The ulcerative colitis is in the whole left colon, right colon, and oh my God, everything. This group has a higher chance of having an pouchitis. Number two is that non-smokers, now I'm not telling anyone to smoke, but non-smokers have a higher chance of pouchitis. Okay. Remember that obesity is a risk factor for a pouchitis. Having primary sclerosing cholangitis and having a P-ANCA positive is more of predisposing to pouchitis. Now, it is nothing that you can do in that. Is that. Now, for those who are preparing for your GI MCQs, there is a difference between a primary pouchitis and a secondary pouchitis. Can you say why does the primary pouchitis happen? It is again because of an unknown thing. And again, probably people say that the same pathology as ulcerative colitis and Crohn's, do not know. But people say that it is because of the gut microbiome. So these are all bacteria, and it is this microbiome which is at fault. Whereas if you talk about the secondary pouchitis, remember, secondary pouchitis is definitely due to a radiation or an ischemia to the pouch. Okay. So this talks about this ones. There are various indexes like pouch disease activity indexes. There are various classifications of pouchitis, like based on the duration. But if you are asked in a single sentence, what is the treatment of choice? What is the treatment of choice for a pouchitis? What is the treatment of choice for a pouchitis? Hello. Sir, the answer is not right. It is not exactly diet. Diet is a part of adjunct therapy. The thing is antibiotics. What is the antibiotic that is of antibiotic of choice in a pouchitis? Very good. Either you use a metronidazole, I really appreciated that answer, or cheap antibiotic, very cheap antibiotic. Ciprofloxacin. And remember, the duration of use of antibiotic is 14 days. Okay, right. So please remember that one. So please understand that pouchitis is treated by that. If this is not responding to antibiotics, as you have said, dietary modifications, then you can go to biological therapy and all of those things. There is another big role for probiotic. Like I do not know how many of you have used some probiotics like say VSLC or those things. So what is important is probiotics, budesonide, steroids are always second line therapy. But the first line therapy for any pouchitis is always metronidazole or ciprofloxacin. The most common bacteria virus that is responsible for pouchitis. The most common virus that is responsible for pouchitis is cytomegalovirus. Okay, so remember that. Now, final one on something called as cophitis. What is cophitis? New term. Cophitis technically means, okay, can I erase this words? Hello? Can I erase this part? What is important is, what is this cophitis story? The cophitis story is a very understand one. Now this is the squamous epithelium of the anodome. This is the dentate, and this is the columnar epithelium. Now the important part is this is the ileal pouch. Now ileal pouch has its ileal mucosa. We all know that. It's not a big deal. Now the ileal mucosa was taken down in this part to become a columnar cuff of ileum. It is in this area that the anal canal used to stay. So this is the internal sphincter. What happens is, in between the transit between the squamous and the ileal mucosa, there happens a transitory epithelium. Below you have the squamous epithelium. Above you have the columnar epithelium. So in between this, there is one area which undergoes a transitional zone between the ileal columnar and the squamose in that. It is basically because of this area or the anal transitional zone that there is an inflammation that is called as appitis. So that means you may say this is a pouchitis. It is very limited to this transitional zone. So that is called as a cophitis and is stated in the same line. So fast, in 5 minutes. It has been a long class. What is the surgical pathology in the appendix? Carcinoid. Come on. Does it look like a carcinoid? Yes. This looks like a mucocele of the appendix. Very good. Okay. As it is a mucocele of appendix, the question is identified. Done. What is the investigation of choice in this disease? First line is ultrasound. Second line or the investigation of choice always for staging the disease. Because it is a pre-malignant disease. What is the complication, sir? Rupture. Rupture can lead to mucinous ascites. But again, we have not been very clear with the terminology. But yes, more than 2 centimeter is to be considered as a pre-malignant lesion and is associated by something called as a pseudo myxoma peritoneae or this one. Now the question to you is, what is the surgical management of choice for a mucocele of appendix? What is the surgery that you are going to do?
Right hand column.
Odi Baba, itna bada. What is the operation that is? Okay, wait.
Depends upon the height of
Depending on site. Size is more than 8 centimeters. Depending on the tip of the base.
Oh, okay. Okay, wait. Question number 1. Lap or open appendicectomy? This is the first question.
Open.
Okay, the answer is not anything, sir. No, lap cannot be done. It is an open appendicectomy for one single simple reason. Even if at a diagnostic laparoscopy you get to see a mucocele of the appendix, please go for a conversion of that patient. Why? Why do I need to convert that? I can do such beautiful laparoscopic appendicectomy. Spillage. Exactly. Spillage. Hence, you are going to do an open appendicectomy to prevent the spillage. Now, coming on to the question. Should I do a right hemicolectomy? This appendicectomy alone. Upon the size. If it is more than 2 centimeters in diameter, it is always good to go for a right hemicolectomy. If it is less than 2 centimeters, no nodes in the mesentery, it is good to take out an N block. An N block excision of the base of the appendix. Remember, please see the line of excision. Please take out the base of the appendix in toto. Then, whatever is opening in the cecal wall, that can be repaired. Next idea is that not a single drop of oxygen should get into the peritoneal cavity. Did I make my point clear? So this is the tip. The diagnostic criteria for diagnosis of a mucocele of appendix on an ultrasound is 15 millimeters. So any radiologist tells you an ultrasound of appendix, the size of appendix is more than 15. Believe me, that is an mucinous tumor of the appendix. Okay, job done. This one now, Mickey Mouse.
The investigation of choice was CCT, no?
Yes, Mickey Mouse. Bilateral. Come on, man. If I oh my God! I thought this was such a sitter.
Diverticulum of bladder. Diverticulum.
Exactly. Sir, it is diverticulum of the urinary bladder. And ureterocele, what would be the picture in an ureterocele? Sir, ureteroceles are inside the bladder. Then in the bladder you have a filling defect like picture. That is the appearance of an ureterocele, and that appearance is called as an adder head. Okay, it can be unilateral or bilateral, or snake head, cobra head, whatever you like to call that to be. The belly love description is an adder head. But this looks like outpouching. Look at the picture once again. Can you see the ureter in this picture?
No, sir.
Now can you see, sir?
Yes, sir. Yes,
Yes, sir.
Array. Can you
yes,
see the
sir.
ureter now? Okay. Can you see the diverticulum?
Yes, sir.
Okay. And right. So if you have seen the diverticulum and this, tell me what are the complications of a urinary bladder diverticulum?
Stone disease.
Bladder stone.
Very good. Sir, it can be a stone disease. Okay. And then
Urinary infection.
definitely. What type of cancer? Transitional squamous and
Transition.
That is the problem, sir. Rest of the bladder mucosa, 90% is TCC, rest of them are squamous and adeno. In the diverticulum, 70% is TCC, 30% is a squamous, probably because the stone in the bladder diverticulum irritates the epithelium. So that is the major point to remember. So that is stone and a cancer. Right. Now, what is this picture, sir? What is this recording called as?
Europhometry.
Wait. This is not a urodynamic study.
Euroflowmetry.
Exactly. This is an euroflowmetry. Please say this. Urodynamic studies are with the differential pressure in the bladder and the urethra. This is not a urodynamic. This is euroflowmetry, where you are going to record what is the flow rates, etc. Now, what happens in a patient with a BHP?
The reduced flow rate. Flow rate is reduced.
I am not very.
Pressure with flow rates.
Qmax.
Very good. That means that reduced flow rate. Okay, so that means that amplitude study is going to come in a big way. Okay, so let us dedicate about 5 minutes because it is appropriate time to dedicate on 5 minutes on this issue. I felt that I should be dedicating some time on this issue also. Now, whenever we talk about an euroflowmetry, please think about that what are the various graphs and what are the things to know about in this one. Now, remember that an euroflowmetry is all about you understanding that what is the graph and what are the various things to know about. Now, if you see this part of the graph, a normal euroflowmetry graph has a particular pattern that is called as a bell-shaped curve. So please remember that. So if I take the graph, because time is short, if I see about the normal graph, on one side definitely you have the flow rate and another side you have the time and another side is the flow rate. Now, what is the normal curve? The normal curve is a bell-shaped curve, and in this bell-shaped curve, where is the Qmax reached? Where is the Qmax reached? Where is the Qmax? By the way, guys, what do you mean by the term Qmax?
Maximum flow rate, sir.
Yes, it is a maximum flow rate after correction of the artifacts. Okay, so in a normal human being, at what time is the Qmax reached? At what volume of the urine is the Qmax reached? Come on. This area under the curve denotes how much amount of urine is coming out, isn't it?
ml per
No, not half, sir. At least 1/3 of the urine, please remember that, at least 1/3. So in a normal human being, remember that to get a bell-shaped curve, the Qmax is reached in the initial 1/3 of the void, usually within 3 to 10 seconds. So a normal graph, please remember, to get a normal graph, 1/3 of the volume is evacuated and you get the Qmax. So this is a normal bell-shaped curve. Now what happens when there is a compression or an obstruction or a compressive obstruction like a BHP? What happens in the BHP? Number one is that in a BHP, the pattern of the graph looks normal until the Qmax is much lower than normal. And as you can see, the Qmax is reached not at the 1/3, but maybe more than half of the urine volume. So this is what exactly that means. Qmax is falling in a BHP. Tell me what happens if this is a strictured urethra. What happens in a strictured urethra? The Qmax is reached very quickly. Very quickly, but thereafter your graph will remain as a plateau. So this is technically called as a constrictive block. This is called as a compressive block. Now consider this one. That means the bladder is contracting. Now remember that there is some detrusor. Now say for example, some amount of dysfunctional voiding is going to happen. Not due to the detrusor, due to the external sphincter going into a spasm and not. That means when the bladder or when the external sphincter was okay, there was some void, then it came to contraction, then it again underwent. And can you see this type of this
sawtooth appearance?
Right. Sawtooth appearance, and urologists will call this to be a staccato curve. And the staccato curve is technically a problem due to involuntary contraction of the external sphincter. Okay. A similar like thing looks like when you have a neurologic bladder or a neuropathic voluntary, involuntary contraction of the detrusor. The patient voids some amount of urine, returns to normal, again the detrusor contracts, again the detrusor contracts, and this happens. So this is more of a sawtooth and looks like the staccato and is an intermittent block. So this is what you are required to know as a general surgeon about what does it look like. Now tell me guys, important things, important things.
Sir, will you put the pictures in that graph, sir? In that picture.
So the first one, have you understood this is a normal one? Hello?
So
This is the normal.
intermittent touches the baseline?
Yes, intermittent touches the baseline. There is a reason. I'm coming to that. So this is the normal one. That means at 1/3 of the volume, you reach the Qmax. What happens in a BHP? The graph pattern looks the same, but the time that it takes to reach the Qmax, by that time, not 1/3, more than half of the graph has been done. And the Qmax is lesser than the normal. What happens in a urethral stricture? Qmax is reached very early. But the amount of the urine that comes out, as you see, looks like a plateau. It takes a long time for the urine to come out. So that is a urethral stricture. What happens if there is an external sphincter which is contracting and releasing, contracting and getting released? So this produces a curve that never touches the baseline, called as a staccato curve. Whereas consider that the bladder wall has undergone a neuropathic change, neurological problems. Detrusor contracts, urine done. Then no urine. Detrusor contracts, urine. No contraction. Detrusor contracts, detrusor contracts. This is called as an intermittent obstruction. Clear up to this point? Okay. Just 2 points before I come to this one. At what Qmax do you determine your need for operation in a BHP?
Less than 10.
Less than 10. Okay. Very good. So less than 10 is something that I really like. What type of operation do you do, sir, in that one? So these patients, remember, do not need an emergency TURP. This patient needs maybe an emergency relief of the urine. Less than 10 is a very right answer that you need a TURP. Okay. So definitely choice of TURP is a big question. Will not come to that. Just two things to remember for your MCQ. Remember that what is the normal Qmax? What happens with age, ladies and gentlemen? It will fall, sir. It will fall, na? Very good. So that means definitely the Qmax will depend upon a spectrum. Just two names to remember. If the patient's age is more than 55 years, that type of a nomogram that tells you the Qmax with age is called as a Cherokee nomogram. Whereas if it is less than 55 years, it is called as a Bristol nomogram. Just know the names, nothing more than that. These are more of MCQ interest points, nothing more than that. But what is important is Qmax is the point that we require to determine the need for an operation.
Sir, will you please explain the graphs given in the picture, sir, in that OSCE? Will you please explain the graph?
In that picture, now see, the patient's flow rate, now this is usually a normal finding. Okay. So this is usually the normal finding that has been done. Okay. Now in this one, this is this point. What they have also done is that this is the normal finding, sir. The lower two graphs under this one are extrapolation of this, where they have seen about that what are the other contractions that are happening. So someone was said about the neurodynamics. I would have said about neurodynamics that I found out the delta P pressure in the bladder. So they have not exactly commented upon any of this in the delta P fraction of the bladder. And hence I did not comment upon exactly this being to be a neurodynamics. All the parameters shown are all uroflowmetric patterns. These two were a derivative from this graphs. Okay, right. Now come to this one.
Sir, what are the findings?
What are the findings?
Sir,
the findings are this is the normal graph. This is the normal uroflowmetry.
Sir, one doubt. What is the
Yes, sir.
What is the significance of post-void residual urine? What is the answer for the question, sir?
So the answer of the question is identify the recording is the uroflowmetry. What are the specific findings in these investigations with BHP to decide? Now, in these investigations, there are no findings to decide. This is the normal findings. What is important is that, as we have said, that Qmax is required if it is less, someone has said, less than 10 ml should talk for an immediate relief of the retention. Between 10 to 15 is usually given with a trial of medications, then followed by surgery. Okay, right. Final words. And someone has asked about something. Yes. So you have said about what happens when there is a residual urine.
Yes, sir.
Hello? Yes, right. So then under
residual urine.
now, significant of the residual urine in the uroflowmetric, will there be a secondary? Sorry. Will there be a secondary small wave in this one? In this part. So this will be the significant. But definitely will not be a very good investigation to comment upon. Okay.
On
Talk about
what will be significant?
on USG, anything more than 200. Post-void urine, if more than around 100 ml, is considered to be a significant in a patient with a BHP. Okay.
Sir,
Now come on to this.
of the
Yeah. 1/3 of the pre-void, or people say more than 100 ml is something that is required. Okay. So please come to this one now. Talk about this change. Okay, ladies and gentlemen, just give me a second. I'll have a gulp of water. Just a minute, please. This one now. What is the diagnosis?
Extradural hemorrhage.
Acute or chronic? Acute, sir. The reason being because the blood is white in color. You know that. Anything more with extradural hematoma, anything more?
With midline shift, sir. With midline shift, sir.
Scalp hematoma.
Very good.
Midline shift.
Is a midline shift. Now tell me, what are the indications of surgery in a patient with a extradural hematoma?
Or GCS. GCS low, sir. With
patient.
History of lucid interval.
History of lucid interval is a diagnosis of an extradural hematoma. Yes. Okay. See, time is short. The volume of the hematoma more than 30 centimeter. I knew about 30. Okay. If you are saying 50, okay, right enough. The
Midline shift won't be 5 millimeter most likely.
No, exactly. This one is much lesser than 5. The thickness of the hematoma, okay, the thickness of the hematoma is more than 15 millimeter. That means this one. GCS less than 8. Number 2 is, remember that with a combination of a volume less than 30 or a thickness less than 15, if there is a midline shift that is more than 5 millimeter, this should call in for a craniotomy. So will be an indication with, remember, a deteriorating GCS, and some of you have said pupillary changes, more of onset of a hemiparesis on the contralateral side, should make you think of doing a craniotomy. Okay, right. How do you know that your decompression has been adequate?
Sir, one second.
Which one, sir? Once again,
Indications of surgery.
the volume of the hematoma is more than 30 centimeter cube. The thickness of the hematoma is 15 millimeter or 1.5 centimeter. The Glasgow Coma score is less than 8 or 8 or less. Even if you have a volume less than 30, thickness less than 15 millimeter, but with a midline shift of more than 5 millimeter, like as very rightly pointed, here the midline shift is not 1.5 but less than 5. Then the Glasgow Coma score, if deteriorating under any size with a pupillary change and with the hemiparesis, should make you think about doing a craniotomy. At craniotomy, how do you know?
Sir, not burhole.
No, sir. Burhole is a temporary procedure. Now, burhole is the first step of doing a craniotomy. Remember that burhole is going to take that part of the hematoma out. Now, with the burhole, if you see that there is an improvement, definitely doing a burhole versus a craniotomy, definitely, as I've said, burhole is the first step of doing a craniotomy. If it comes out with a burhole, again, it will be an easier option. The patients, because this is the first and the most important thing. How do you know that the brain is, or your hematomy evacuation has been adequate? So it is usually by return of a brain pulsation. So please remember that one. So burhole, as I've said, is the first step where you are going to take that out. Okay, if the patient's BGCS does not improve, or if there is no immediate improvement within half an hour to 40, then they are better going to consider a craniotomy. Okay, now someone said about lucid interval. Remember that lucid interval is an indicator of doing.
Sir, after burhole, whether the patient condition is improved or not to go on for the craniotomy.
No, see, again, that depends upon the neurosurgical opinion, because they are going to aspirate out they are going to take out the hematoma. Now, the main part of taking out the hematoma is that preoperative CT scan is going to dictate what is the volume of the hematoma. Now, if after taking out the burhole, the dura can be approximated on its own. That means if you have done a burhole, remember that a burhole exactly looks like an opening where before you have taken out the hematoma, there is a big clot of blood in this one. And after you have taken out the hematoma, you should be only seeing the dura. Now the point in the story is that after you have taken out the hematoma out like this, if the dura is still compressed, that means if this is a normal brain parenchyma, the thing that we expect is that the dura will immediately come back. The dura has to come back immediately.
Recoil back.
They all recoil back because the brain pulsations have returned. If that happens, you have done a good job. If that does not happen, that means there is more amount of blood to be taken out. That is one of the indicators that a neurosurgeon does to do that. Okay, right. So this is all about. What is this pathology?
Marjoram sir.
Post-burn contracture.
Post-burn contracture, but with the post-burn contracture, I see a non-healing ulcer if you have written a marjolin. Okay. What are the complications in a post-burn contracture or marjolin?
Melanoma.
The main thing is
joint movement.
okay. Right. So the main thing in complications is, remember, if I have written marjolins as the answer, then it would have been an invasion of surrounding tissue, thereafter followed by a distant mets. Now, a very quick take on if it is a post-burn contracture, then complications would have been a contracture in the joint and a marjolin.
Sir, in identification of pathology, do we have to describe the ulcer?
No.
Slope and all.
We have said identified.
Okay,
We have not said described. If it is described, then it is margin. Now, a few things on marjolin's ulcer. What are the scars that are more liable to lead?
Scar.
You can have answer on both the fronts, sir. Either it is a post-burn contracture or it is a marjolin. Both of them are acceptable.
Or not. Sir, can you describe the ulcer also? It will be a quick revision.
Just a second then, let me erase all these pictures. Site of the ulcer is the lateral aspect of the foot. This appears to be the left foot, I hope. The surrounding shows a scar which has not healed well given the hypopigmentation. The margins of the ulcer are not well defined.
Irregular.
Next, or irregular. The floor of the ulcer is filled up by necrotic tissue. The age of the ulcer, or the age of the ulcer is this. I am not very sure because I am seeing it in a 2-dimension. It may appear to be either a rounded edge or it appears to be an everted edge, any of this one. So the edge is this one. Either it is an everted edge or a rounded edge, probably an everted edge. I would like to feel the base of the ulcer or palpate the ulcer for any induration. And after this is done, definitely I would like to go for local examination of the neurovascular joint,
Discharge.
arterial, definitely discharge, I missed that point, and the vein, and most importantly, I would like to see the regional lymph node.
Thank you, sir.
Okay, so this talks about what are these ones. Now, few things to know about the marjolin. So, what are the scars that can be responsible for giving a marjolin?
It's a chronic venous ulcer, sir. May sometimes leads to
Chronic long-standing ulcers.
Okay, in a bond, what is the mean duration?
5 to 10 years.
If it is within 6 months that a marjolin develops in a, or a cancer develops in a scar, that is called as an acute marjolin. If it is more than that, that is called as a chronic marjolin, but these are all very non-standard definitions to be had. If you search the literature, you will get that. Which is the most common cancer to happen in a marjolin?
squamous cell carcinoma.
What is the second most common? Basal cell. Rare ones could have been a melanoma. Then comes sarcomas. Okay, right. Now, the diagnosis of choice is always by taking an incisional biopsy and thereafter to decide on how much should be the margin of resection. Now, the margin of resection is usually the gross macroscopic tissue is at least a centimeter that should be resected. Now, what is important is marjolins versus a de novo squamous cell cancer. Which one is more aggressive? Marjolin or squamous cell cancer? Which one is more aggressive?
De novo, sir. De novo.
No, sir. Absolutely
Squamous
not.
cell carcinoma only, sir.
No. The marjolins is more aggressive than a squamous cell because for only one reason, the marjolin cannot spread to a lymph node. Do you know the reason? That is because there is a scar tissue.
Already dead tissues.
Exactly. But the minute that marjolin comes out from this area and invades the soft normal tissues, that's it. We had it. It will spread rapidly to the nodes. So remember that marjolin as such is more aggressive, but the propensity to spread is less because of the scar tissue. And hence, in marjolins, there is a big question of doing a sentinel lymph node biopsy. Remember that squamous cell cancer sentinel lymph node biopsy is a standard of care. In marjolins, we do not do the sentinel lymph node biopsy. Okay? Right. Job done. The last topic.
In melanoma, we do the sentinel lymph node biopsy, right?
Yes, always, sir. But marjolins, no, sir. This one is very squamous cell, you do that. Okay. This question. What is your diagnosis from this 53-year-old male patient who developed a positive discharge?
Tetanus.
Diphtheria.
Clostridium.
Come on.
Sorry, sir.
Man.
Tetanus.
Array, this is tetanus, not
Tetanus, sir.
Clostridium tetanus.
Tetanus.
Okay. Treatment options at this present moment.
ABCD.
ABCD. Very good. A is airway, B is
Breathing.
breathing. Okay, breathing means ventilation, good enough.
Yes.
C is
Circulation.
okay. D is
Drugs.
drugs. Okay. Disability. अच्छा, ठीक है, चलो, disability. Okay. Sir, then I would have better said that resuscitation, as you have very rightly said, management of the airway, breathing, circulation. But the most important part of this is, remember, mechanical ventilation is the requirement at this stage with the muscle paralysis. This patient has already gone to a state of tetanus. Now, parallel to this, after you have done this patient also needs an anti-tetanus globulin. So please remember that. What is the dose of anti-tetanus globulin? That's something that I'm going to ask you. That I know is a bad question.
500
6,000.
adults, sir. 500 international unit per adult and
Very good.
250, sir. 250 international unit per children.
Okay, so let us have it very quickly done. I know that this sounds very, again, boring thing.
Prophylaxis.
Wait. We nowadays get something called as anti-tetanus globulin. We do not, now, where is this anti-tetanus globulin derived from? Human beings or horses?
Horses.
Horses. This is the reason I asked you this question.
Now it is humans.
Array, this is the horse, man, horse. Okay, we do not derive it from horses anymore. That was called as anti-tetanus serum. We derive it not from horses anymore. Whatever we use is from human beings, and this is a, remember that this is a human immunoglobulin now. So there is no question of any anaphylaxis. Please remember that. Okay, so this is more than 100 times effective than an ATS. There is no anaphylaxis. What is the treatment therapeutic dose of an anti-tetanus globulin? The dose is at least 3000 international unit IM single dose. Please remember that one. The dose is 3000 units IM single dose. If you are mentioning 500 units, that is a prophylactic dose for the wound. Please remember that. This is a patient with the French tetanus. You may give that wound with the 500 units of that. But this patient needs a systemic dose of 3000 international unit of an anti-tetanus globulin. Okay? So more or less we have discussed many theory discussions. Yes.
For the wound, locally we don't need to wash with globulin.
Sir, time is short. Definitely, you need to do hydrogen peroxide, wash, debride. Definitely, management of tetanus comes in undergraduate as a long question. You don't know that. Yeah. Please, can you kindly repeat?
For the wound management locally, shall we
wound management locally, shall we use the anti-tetanus globulins? Should we wash with the anti-tetanus globulins?
You will need number one, a cleaning with normal saline. Number two, giving local injections of 500 international units because the toxins are being produced from the local places. Number three, you need a debridement and along with a dressing with hydrogen peroxide. That is probably the only place where hydrogen peroxide is still used. But in an established tetanus with a convulsion and neck rigidity, the main important point to know is only one: systemic administration of anti-tetanus globulin. Okay? Chalo.
Okay.
So, ladies and gentlemen, IM. Yes, not IV. So, we had a long discussion class. Thank you.
Sir, you teach very well, sir. Thank you, sir.
Thank you. Thank you so much.
Thank you,
So,
sir.
the questions were very simple, I think. How much did you score?
The simple questions are tougher, sir.
Okay. That these things are
No, sir. Actually, it was seeming to be easier, sir. But after discussion, sir, actually, they are much tougher, sir. Actually,
okay. So please remember that
much of those things.
Exactly. So this exactly happens. I think that Dr. Rudrajit Sinha is here. We'll be discussing some amount of statistics, etc. Okay.
Right. Okay. Thank you, sir.
Okay. Thank you. I'll be leaving now. Rudrajit, are you there? Hello? 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 Shilajit, is Rudrajit there? Hello? No. Shilajit?
Sir, off the beat, sir. I want to say something, sir.
Yeah.
Sir, recently you have taken a class. You have presented a presentation in a sir about the soft tissue infections and the different abscesses, sir. So, sir, if you take that class again, sir, in this forum, sir, then
Okay, then I will be there.
with elaboration, sir.
Okay, which
Sir,
time?
that class was very rapid, sir.
Yeah, definitely. Time is always an important thing. Definitely, I'll be trying to take that. Abscess drainages. Okay, I will be there.
Yes, sir. Take it.
Okay. Shilajit, okay, Daro. Shilajit, are you there with us? Hello.
Sir, one doubt, sir.
Yeah, please.
Sir, in hernia surgery for iliopubis tract, it is the continuous surgery, sir.
I could not understand. Hello.
Sir, yes, hernia surgery.
Just a minute. Shilajit, are you there?
Yes, sir.
Okay, Shilajit, Dr. Rudrajit Sinha will be joining today.
Sir, I'm just asking, sir, and then
Okay, so please. Okay, now, sir, coming back to your question. So, your question is that in a hernia surgery, what will you do with the iliopubis tract, isn't it? Now, see, the main point of mesh fixation is always a very. Now, it all depends upon how much is the tensile strength of the tissue. Now, if you use the anterior superior iliac spine and the inguinal ligament has a layered structure. Now, all of us have done hernias. We have done many hernias. Now, you do not fix the mesh in one point, do you? Because if you fix it in one point, the problem is when you put in a spool, that fiber is going to tear out. So what people do is that rather than do it on the inguinal ligament, the iliopubic tract is usually a band of tissue. So this is the band of tissue. Okay. So this band of tissue takes in these bites sometimes. So you are going to take off band of tissue, some fibers of the inguinal ligament. So this is the basic idea is that to keep the mesh in place. That's it. Okay.
Sir, there was a question that was asked in the OSCE exam.
Just a minute, Shopti, can you please kindly repeat that?
Yes, sir. There was a question that was previously asked. I mean, I can't disclose where. Obviously, you can understand the size of a mesh in a laparoscopic hernia repair was asked. the specific size, is it just to cover the myopectineal orifice of Fusha, or is it a 15 by 12 or something we have to write?
7.5 into 15 is what?
See, again, whenever you are talking about the size in a laparoscopic repair, the best answer is probably to cover the myopectineal orifice. Now, if you are mentioning 7.5 by 15, this is usually the standard mesh size that is available. Now, say for example, the patient is 8 feet in height. He comes from Scandinavia and is 8 feet in height. Versus someone who comes from Africa is a pygmy who is 4 feet in height. Do you think that both of them are going to need the same mesh? Absolutely no.
No.
So definitely, as you have very rightly said, it all depends upon the ability of the mesh to overlap the myopectineal orifice with approximately 3 centimeter to 5 centimeter with a gap. So that if there is a displacement of the mesh, it can take care of that. I think the size criteria will be the more important one.
Okay.
Hello?
Thank you.
Yeah. Hello?
Yes, Shirajit.
Follow.
Sir, Dr. Udeshna will not answer.
Okay, then sir, I will be leaving then. Okay, thank you.
Thank you, sir.
Okay, thank you everyone.
Thank you, sir.
Okay, best of luck for the exams. Right.
Thank you.
Thank you very much.
Thank you, sir.
Thank you, sir.
Okay, let us start now. Okay, a very good evening, everyone. We will start with the OSCE session. Before that, the format that we usually follow is the next 15 or 10 or 15 minutes approximately. Please keep your papers and your pencils ready so that we can discuss about, or you can write the answer that you feel will be the most appropriate. And then after the next 15 minutes, I will be taking you through the discussion part of the OSCEs. I hope that every one of you is ready with your pencil, pen, paper. So please focus on the screen and just a second, please. Yeah. Now, I hope the screen is visible to all. Hello? Is the screen visible to all, please? Hello?
Yes,
Am I
sir.
audible? Yeah. So please get ready. We start. The first question of the day. This is not a quiz, so please remember this is how exactly an OSCE session is going to be asked in an examination. And all of them are things that you do probably every day in your wards. The first lot of the day today are things that are concerned mostly in general surgery, or as a surgical resident, these are things that you have encountered. What is this device and what is the flow rate of fluid through this? I hope that this is an easy question. You will get 30 seconds to answer this. Definitely we will have a detailed discussion of this. Okay. Can I go to the next question, please? Can I go to Can I note it from the... Can I go to the next question? Hello?
Yes, yes.
Now, this is a intravenous crystalloid, or this crystalloid has been shown. The question that has been asked is, what is the potassium content and the pH of this crystalloid? Now, you have used this fluid more or less every day in your clinical practice. And the second question is, what is the use of this fluid in a surgical emergency? So the question is, what is the potassium content and the pH of this crystalloid? And what is the use of this fluid in a surgery emergency? Okay, so please tell me when you are ready. Hello.
Okay, sir.
Thank you. The third question. You are being shown a device that is used in lower limb surgery. Identify the device. The physician concerned is applying a device to be used in a lower limb surgery. There are three questions in this lot. Identify the device being used in the lower limb surgery. What is the maximum time for the application of this device? And what are the contraindications of use of this device? What are the contraindications of use of this device? Okay, if you have completed, so we will. Good. Please, we'll take time in this one. A patient was rescued from a collapsed building, and after resuscitation, an ECG was done. Now you must be wondering, as a surgeon, okay, why should I be giving you this one? Because this is a common scenario that you get in an emergency setup. What is the probable abnormality that has been shown? Now remember, we are not medicine guys, and then I do not need you to be good in medicine. This is for all of us who work in an emergency and a trauma, and for every one of you working every day in your clinical practice, this becomes an important question. How shall you manage this specific abnormality? Okay, I will show you the ECG very clearly. Can I go to the next question? Can I go to the next one?
Yes, sir.
Okay. Identify the abdominal closure technique. What is the principle of use of this technique? Okay. Can I go to the next one? Hello. Can I go to the next question?
Yes, sir. Yes, sir.
I have been shown a suture. Everyone knows this suture. I have shown you the suture fragment also. None of the parts of the picture has been shaded for you. But the only question is, what is the specific use of this suture? You have been shown the needle, you have been shown the suture thickness, and what is the absorption time of this suture?
Yes, sir. There is.
Another question with a suture. You are being shown a suture and you have not been shown the suture material, only the suture packet. And this suture is used, what is the use of this suture in general, that is GI surgery, and in emergency surgery? What is the absorption time? Can I go to the next one? Hello, can I go to the next one?
Yes, sir. Yes, sir.
Simple question, undergraduate style. Identify the instrument. What is the use in general surgery? Please don't say cord clamping. Can I go to the next one? Okay. Now tell me, what is this instrument? What is the use in general surgery? This is very easy. Okay, can I go to the next one? Hello, can I go to the next one?
Yes.
Okay. This one. Identify, sorry. I think you will be seeing this part of the instrument, and this is what is going to be making the difference. What is this instrument and what is the use in general surgery? Do I have another picture? No, I don't. So I can increase the picture for you. Okay. Can I move?
Yes, sir.
Another step. No? Identify this instrument. What is the use in general surgery? Okay, I think we shall go to the next one. Sure. Now, please see this picture very carefully. This is an instrument set, and the question that you are asked is, out in this instrument trolley or the set, identify what is C, what is D, and what is M. Or I will mark these things for you. This is C, this is D, and this is M. D, C, and M. The other question was, what is this set used for? Simple question. Okay, 11th question done. 12th one. Now, this is a 60-year-old gentleman who was admitted with chest pain following blunt trauma to the chest. What are the findings on the X-ray? Appears as an undergraduate question, simple question. See the X-ray. What are the findings on the X-ray? I think there are multiple findings to think over. Okay. Okay, can I go to the next one? Hello? Can I go to the next one?
What are the questions?
The questions are, what are the findings in the X-ray? You should not be always exposed to a very articulate question. Some questions will always be fake, like this one. Okay. Next question. Another X-ray, beautiful X-ray. 10-year-old was admitted with a blunt trauma to the abdomen and X-ray of abdomen was done. What is the diagnosis? Which is the most common organ involved in the pathology? And what is the eponymous? Eponymous means named radiological sign that you can see very beautifully in this patient. Okay. If you want to have a look at the X-ray again, have a look at the X-ray. Okay. Can I proceed to the next one? Can I proceed to the next one? Hello?
Yes, sir.
The 14th question. You are being shown an investigation which is being shown, or what is the investigation that is being performed? Number 2, it is measuring something. What is the grading system that is used for this condition? Okay, can I go to the next one? Hello? Can I go to the next one? Hello? I think the last question in the lot.
Yes, sir.
Identify the degree of burn in their limb. What is the imminent complication that is happening due to this degree of burn? Okay, this is the last question of the day. Completed? Hello? Completed?
Yes, yes.
Good. So let us start with the first one then. Right. Let us start, ladies and gentlemen, with the first one, and I feel this is an easy question. Identify the device and what is the flow rate through this device. Okay. So now tell me, what is this device and what is the flow rate through this device? What is your opinion on this one? This is a very simple question. Every one of you have answered. Okay. What is this device?
IV cannula.
Anything more than an IV cannula?
16 gauge. 16 gauge IV cannula.
Okay. Right. Now, now, the important thing is, see, the important thing to remember is
14
that.
gauge.
Very good. So this is an 14 gauge orange colored, you can appreciate the color orange, intravenous cannula. Okay. Now, what is important is, what is the flow rate? What is the flow rate through this? Is a standard flow rate is at the rate of 240 ml per minute. And thus 500 ml, or better called as, in a trauma scenario, 1 liter of a crystalloid is infused approximately at the rate of about 5 minutes. Now, talking about IV cannulas, you must be wondering why have I started the day with an IV cannula? Because in an OSCE examination, remember that there are multiple domains that the examiner is trying to test. The first one of this that you are being tested or you are being shown in this one is you are being shown what exactly is the basic word exercise that you are expected to do, like this one. Now, when you talk about an IV cannula, remember that when you talk about an IV cannula, what we remember in an IV cannula is, now when I teach my undergraduates, this is exactly the way I more or less do teach my undergraduates. Now, see, what I do is that when I tell my undergraduates how to remember the size of an IV cannula, I tell them, draw this beautiful picture, and I tell them that what is at the center of Earth? At the center of Earth, you have some molten lava. What is the color of molten lava? It is orange in color, and thus the largest of the cannula is a 14 gauge cannula, which is orange in color. And remember that the flow rate is about 240 ml per minute, which is the largest. And it is used in which scenario, ladies and gentlemen? In which scenario do you use?
Trauma.
Exactly, in a trauma. And is the only exclusive use. The only caution is that it is probably the largest or the widest of all cannulas. So please remember that. Now, if you go a little up from the earth, so we are going towards the sky, that means you get those rocks in place. Now, when you get those rocks in place, I teach my undergraduates that when you get those rocks in place, what is the color of a rock? The color of a rock is gray in color. So what is the flow rate now through what is the size of a gray cannula? Is 16 gauge. What is the flow rate through this? Is 180 ml per minute. Okay? Right. What is the scenario in which you use this cannula, a gray cannula? Come on. This is very simple. Again in trauma. Burns and in burns. Okay. Now over the rocks, what is the next thing that you get? You must be smiling now, sir. We get grass. What is the color of grass? Color of grass is green. So now tell me, what is the size of a cannula or a green cannula? 18 gauge. Okay. What is the flow rate through this? 90 ml per minute. What is the use of a green cannula? Again in trauma, sometimes in blood transfusion in a trauma, and in elective surgical procedures. Okay. Now, over this, you get, now you will be smiling at my corollary, you get a bird which was pink in color, or you get a flower which is pink in color. So it depends upon how do you wish to remember this. And what is the color of a pink cannula? 20 gauge. What is the flow rate through a pink cannula? 60 ml per minute. You will be wondering that how do I remember that? Well, it comes by practice. And remember that this is only for IV fluid infusion in non-shock patients. Okay. Now, over this, after this flowers and this grass business, let us come to the sky. And when you come to the sky, what is the color of the cannula? Is blue. Okay. What is the size of a blue cannula? 22 gauge. What is the flow rate through a blue cannula? Is about 35 or 30 ml per minute. What is this IV fluid used for? It is used in children for a rapid blood transfusion, or even sometimes in neonates for trauma resuscitation. Now, what is something beyond the sky is the sun. What is the color of the sun? Color of the sun is yellow. So now tell me, what is the important point to remember in a yellow cannula? What is the gauge of a yellow cannula? 24 gauge. Okay. What is the flow rate? 20 ml per minute. And is usually always used in neonates, not in children. And then beyond this, you have the thinnest cannula possible maybe. That is usually again violet in color and is of a gauge of 26 gauge, has the least flow rate of about 12 ml per minute. Is something that we usually only use in a neonate, very rare to get. So for your surgery examinations, we are required to know an orange cannula, a gray cannula, a green cannula, pink cannula. I hope you'll remember this. I made this undergraduate scheme in mind so that you can remember this way, in which how we remember about an IV cannulas. Any questions in this one so that we can proceed very quickly to the next one? You don't think any? Let us go to this one. Now, let us talk about this. Now, whenever we talk about this IV cannula business, now talk about this IV cannula. What is this fluid that I am showing you? Come on, what is the fluid that I am showing you, ladies and gentlemen? Ringer's lactate. A little quick things about a Ringer's lactate. Now, Ringer's lactate is also equal to something called as a Hartmann solution. Now, this Hartmann, gentlemen, is not the same as our Hartmann's procedure in surgery. They were two different. This Hartmann was technically a pediatrician. Okay, just a few things in history, because some of you are good students and you will be asked about that. Who invented this solution? Any idea that is given in your suggestion? Who invented this solution?
Dr. Ringer, Dr. Ringer.
Very good. This gentleman called as Sidney Ringer. Okay, and was modified by a pediatrician called as Hartmans. And this is what is important in this. Now, what I am interested is, what is the content in 1 liter of a Ringer's lactate? If you are in your hospital now, please grab hold of 1 bottle of Ringer's lactate, and please understand that this is something that you cannot afford to forget in an examination. 1 liter of a Ringer's lactate solution contains about 130 millimoles per liter, or 130 milliequivalent, because this is a monovalent ion, that is sodium, of sodium. Okay. It contains about 110, some people say 109 millimoles per liter, or a milli equivalent of chloride, which is again a monovalent anion. It contains about 28 millimoles per liter, or a milli equivalent of a lactate. Remember that lactate again as a single anion. It contains about 4 millimoles per liter, equivalent to an 4 milli equivalent of a potassium. This is a monovalent. Okay, and as calcium is divalent, it contains 3 milli equivalent, which is more or less equal to about 1.5 millimoles per liter of a calcium, which is a bivalent. So what you are required to remember for an examination is that a Ringer's lactate for all practical purposes contains sodium, it contains chloride, just a second, where did the marker go? Yeah, it contains sodium, it contains chloride, it contains lactate, potassium, and this. So the question that was asked is, what is the potassium content? So now can anyone tell me what is the potassium content in a Ringer's lactate? Quickly please. Potassium content.
So 2 millimoles.
Not okay. In this crystalloid.
Yes,
So remember that 500 ml contains 2 millimoles, or better is if you say this part, they always quote it as 4 millimoles per liter. Okay. So you may say in 500 ml, that is 2 millimoles, but it is 4 millimoles per liter. Now coming on to the pH. What is the pH of this solution? What do you feel is this pH? Is it alkaline or is it acidic? What is your opinion on this one?
So it is isotonic with plasma.
It is, wait, guys. Sir, we are talking of the pH. We are not talking of the
Alkaline,
osmolality.
sir.
No, sir. How can it be alkaline? Come on, man.
Lactate.
It contains lactate. How can it be alkaline? So the pH of this is 6.5. Okay, the pH of this is 6.5, and the lactate quickly metabolizes and goes to the liver and produces what, moiety?
Bicarbonate.
Bicarbonate. And this is this reason. What is the use of this entity is given by another answer. What is the osmolarity of this one? The osmolarity of this is about 273 milliosmoles per liter. What is the osmolarity of blood? About 280 milliosmoles per liter. So by this reason, hence, a Ringer's lactate for all practical purposes is the crystalloid which resembles the composition of the plasma, more or less the closest. And the lactate is metabolized either by a citric acid cycle and metabolizes, remember that, generates a carbon dioxide which dissolves in the water. I'm teaching chemistry, it seems. And then it mixes with the water and the carbon dioxide, makes a bicarbonate. And thus the bicarbonate is used to combat metabolic acidosis or alkalosis. Metabolic acidosis or alkalosis?
Acidosis.
Very good. And thus, what is the use of this fluid in emergency surgery? What is the use of this fluid? Very good. So this is a fluid of choice, particularly when you expect a metabolic acidosis in burns and in trauma, and is the crystalloid of choice. Okay, though we have had a war between normal saline and Ringer's lactate, but majority of surgical emergency guidelines across the world go for formulation of a Ringer's lactate in preference to a normal saline. So these things goes on changing across various guidelines. So burns and trauma should have been a good answer. Now, come to the third OSCE. What is this use? What is the device that I'm showing you in use? This is an important question and will tell me that you have visited your operation theater very meticulously.
Sir, arterial tourniquet.
Very good. I really am impressed. So this is an arterial tourniquet and I really appreciate your answer, sir. Okay. So for those who have not seen what is a tourniquet, so the first question was identify the device being used in lower limb surgery. So this is called as a tourniquet. If you have used the word called as an arterial tourniquet, okay, I am again happy. Yes, arterial tourniquet is a good answer. Now the few things to remember in a arterial tourniquet. First of all, what is the use that you know of an arterial tourniquet? In your surgical experience, what is the use of an arterial tourniquet?
So to reduce bleeding in any peripheral limb operations like tendon repair.
Okay, so let us talk about elective operations. As you have very rightly said, to make a bloodless field, isn't it? So this is a single line summary of this one. Can you mention an emergency use of this one? An emergency use.
Traumatic amputation.
Very good. And traumatic amputation particularly, or a limb trauma where there is a severe blood loss. But is this the treatment of choice? No. This patient needs some transport. Remember that. And this can only be used for the urgent transport in which you need to stop the bleeding. And that is only used in a trauma. Okay. Now, in an elective use, have you seen your anesthesia colleagues use this for some particular type of anesthesia? Hello? Have you known this anesthesia use?
Regional IV intravenous.
What is this type of block called as? Intravenous block or Bayer's block. Or I have really used this again in something called as isolated limb perfusion. In which condition is it done?
Sarcoma.
Very good. Melanoma and soft tissue sarcoma. So as a surgeon, it is important for you to remember this one because at the surgical postgraduate examination, these things are given. Now, please tell me, what is the pressure that you are applying in this tourniquet? Above the systolic blood pressure. Remember that the logic is very simple. If it is the upper limb, then it is 100 millimeter mercury more than the systolic. So if the systolic pressure is say 150 millimeter of an individual, for an upper limb add 100 and it will be 250 millimeters of mercury. Whereas if it is a lower limb, then it is add 200 to the systolic pressure. And thus, how much will be the lower limb tourniquet pressure?
350.
Is 350. Remember that this is for your manual counting. Okay. If you use a Doppler, the things go a little down. That's it. Now talk about the tourniquet time. This is the most important thing you are required to know. I took up this question from your chapter in surgical safety. Now tell me, what is the tourniquet time allowed for a tourniquet?
2 hours.
What is the tourniquet time that is allowed for a tourniquet?
2 hours. 2 hours.
Maximum time, very good. the maximum time that you have said as in this question, remember, is 2 hours is the maximum time. After 2 hours, the rule of the game is very straight. Remember that initially, what you are required to do is that use for 90 minutes, preferably at 60 minutes. In the first hour, it is preferable to use the tourniquet for a continuous time of 60 minutes. And then the maximum time allowed can be 120 minutes, as you have said, is 2 hours with the tourniquet. So if you have not known this, please remember the time you are tying the tourniquet, please start the watch and tell your anesthesiology, please tell me at what interval that I need to have the tourniquet removed. What is the time that the anesthesiologist should be telling you that you have a tourniquet in place? Remember that, not 1 hour, sir. It is a 30 minutes gap for the first 2 hours. If you have crossed 2 hours, stop, open the tourniquet for a time of 5 minutes, and then reapply the tourniquet for the procedure. So please remember that. But if you have reapplied the tourniquet, remember that your time for the application is technically going down. Okay? Now, the question that you are asked is, if this is the tourniquet, as you can see, what is this device? Hello? What is this device? Hello? Come on. All of you have applied a tourniquet, I think. What is this thing? This is the cuff, isn't it? Now, what is this black colored thing? Come on, man. What is this thing?
sheet वगैरह ताकि उसके लिए
Sir, it is not exactly a sheet. This is the reason I asked you this one. In your practice, do you use a sheet? I use an orthopedic
cotton roll.
Cotton roll. Very good. I use an orthopedic cotton roll. And what is the overlap that you are allowed to do? Because these are all standard things that you go or learn from your operation theatre. What is the overlap that you are allowed to do? Is usually a gap of about 3.5 inches maximum. Okay? You are not allowed to go beyond that, because if you go beyond that, the thing becomes loose and your tourniquet effect doesn't become that tight. So it is usually a 3.5. So the usual tourniquet has an approximate size of about 8 to 8.5 centimeters. Okay? So the overlap is about 3 inches rather than centimeters, which is a big overlap. And this is what you are required to know for a tourniquet. Now we are not going to talk many things in a tourniquet, except that tourniquets have many bad things, as I have said. This is all about a surgical safety chapter. You can read about tourniquets and many things about tourniquet. I am more interested in what are the contraindications of use of a tourniquet, as has been asked in the question. Can you tell me what are the contraindications when not to use a tourniquet?
Ischemic limb.
Very good. Really appreciate that answer. So I think I can erase this part of the question. Okay. So the first of this is an ischemic limb or a peripheral vascular disease. Really appreciate that. Just a second, please.
Underlying deep vein thrombosis.
Okay. Underlying deep vein thrombosis. Really good. So the first one is a peripheral vascular disease. The second one could have been an underlying DVT. Good one. Number 3 is an arteriovenous fistula. Number 4 is a peripheral neuropathy. Okay. Number 5 is an impending compartment syndrome. Right? Okay. Number 6 will be sickle cell hemoglobinopathy. Can you tell me why is a sickle cell hemoglobinopathy a contraindication of use of this thing?
So it causes sickle cell crisis.
Very good. And so what will happen in the limb thereafter? It will lead to It will lead to a circulatory stasis, occlusion of the capillaries and the arterioles, and thus, when there is a reperfusion, there can be digital or limb ischemias. So this is something that you are required to know in this part. So these are the contraindications of use of a tourniquet. Now tell me, what are the nerve injuries that are more prone to occur after use of a tourniquet? What are the nerves that can be injured after a tourniquet? Is an MCQ.
Lateral cutaneous nerve of thigh.
Lateral cutaneous nerve of thigh is not the right answer, sir. Come on, man. How can you injure the lateral cutaneous nerve of thigh? Lateral cutaneous nerve of thigh will be in this part. Hooray. Sir, in the upper limb, always remember the most common nerve injured is always the radial nerve, followed by the ulnar, and thereafter followed by the median. So the median is the least common nerve that is injured. The radial is the most common nerve injured. In the lower limb, always remember that the sciatic nerve is always injured. See, when you talk to your plastic surgery rotations, or when you go to a plastic surgery or your orthopedic surgery rotations, it is said that the larger is the nerve, the more or the thicker is the nerve, more is the chance that that nerve is affected by the application of the tourniquet. So always remember that in the lower limb it is the sciatic nerve, and in the upper limb it is usually the radial nerve that is affected. So this completes your MCQs or your OSCEs on tourniquet. Any questions or any queries, please? Till now.
Sir, can you repeat the sickle cell hemoglobinopathy?
The sickle cell problem produces, now you know what is the sickle cell hemoglobinopathy. And in a sickle cell anemia, what it problem produces is that it produces a clumping of the RBCs. And when there is a reperfusion in an acidotic environment due to application of the tourniquet, it is going to produce an occlusion of the arterioles and the capillaries, particularly of the digits. So in a limb with a sickle cell anemia, it leads on to an end or a digital ischemia. So that is the reason for a contraindication in a sickle cell anemia. Okay, right. Now, let us go to this next question. Patient was rescued from a hyper. What is the probable abnormality due to? Hyperkalemia. Very good. So I hope that every one of you have seen this X-ray. All of you know what is an hyperkalemia. So you are asked about an OSCE. Quick OSCE on hyperkalemia. Quick OSCE on an hyperkalemia. So whenever we talk about an hyperkalemia, remember that whenever we talk about an hyperkalemia, what is the etiology of hyperkalemia in this case? What is the etiology of hyperkalemia in this patient? Very good. So the etiology, sir, is due to a crush injury which produces a myolysis, and a lysis of the muscles or tissue damage produces an increase in the potassium levels in the blood. Okay. So we are not going to talk what are the other causes of hyperkalemia, etc. We are going to talk about the treatment and the problems of hyperkalemia quickly that the surgeon has to know. Now tell me, what are the clinical manifestations of a hyperkalemia? Oh, by the way, what is the normal level of serum potassium? I really forgot. What is the normal level of serum potassium?
3.5.
3.5 to 5 is said to be the normal level of potassium. There are books which says that greater than 5 is hyperkalemia. There are books which says that no more than 5.5 should be called as hyperkalemia. But for all practical reasons, remember that ECG changes are seen when the potassium levels exceed more than 5 milliequivalent per liter. So it is good to consider 5 as a cutoff for potassium. Now let us talk about what are the clinical problems that happen in hyperkalemia, or what is the most common manifestation of a hyperkalemia? Not, sir. Is weakness and fatigue. And remember that later on, muscle paralysis, cardiac arrhythmias are much late features of a hyperkalemia. Now, in a surgical patient, understanding weakness and fatigue is a very difficult thing for all. But this is in an elective patient, you may have that. Now, as you have very rightly said, cardiac arrhythmias are which type of arrhythmias? Tachyarrhythmias or Bradley arrhythmias? No, sir. Remember that potassium more slows the heart. More potassium is responsible. So we are not going to talk physiology of the heart. Remember, the story is very simple. More potassium slows the heart. So I do not know how many of you have known about again execution by lethal injections. Do you know what is the more common ingredient that is used for lethal executions or injections that are used for potassium? Not exactly, not cyanide, sir. It is used for potassium chloride and a muscle relaxant like atracurium, etc. And potassium chloride, patient has a sinus bradycardia, sinus arrests. Okay. Now, followed by a ventricular tachy and others. So we are not going to talk that. But we are going to talk a few things about ECG that we surgeons should know. I think that all of you can identify what is this ECG change that you can see in this picture.
Tall T waves.
Very good. So the first thing that I, even as a layman, can identify, you guys know this much more than me, is that wow, these T waves are wow, man. Even. So even if I do not know an ECG and I do not know to identify an ECG and an EEG, but still I can identify something called as a tall T. And what is the first now for an MCQ? What is the first ECG change that happens in hyperkalemia? As a surgeon, you are required to know that. What is the first ECG change that happens when the potassium is between 5 to 5.5? Remember that T waves or tall T waves start appearing. And what happens is that something called the PR interval story, okay, and the PR interval becomes prolonged. So this is what my medicine colleagues and my critical care colleagues tell me. Now, if the potassium goes from the level of about 5.5 to 8, something called as a moderate. So if this is mild, this is moderate, is 5.5 to 8. Remember that. What is the ECG change that happens, ladies and gentlemen? What is the ECG change that happens? The only thing is that the QRS complexes, remember, they become wide. So we are required to identify this one. Okay. And when it crosses 8, then what is the first thing that happens? Is that there are all groups of changes. It could be a sinus wave, it could be a ventricular fibri, it could be even an asystole that happens. So you are required to know that by an ECG, this is the way a critical care physician, they identify that, okay, the potassium levels are going to be really bad. And this is the way they identify how much bad is the potassium levels. Okay. Now, tell me how to treat a patient with a hyperkalemia, because you have been asked this question. How to treat a patient with a hyperkalemia? How to treat a patient? Okay, good one. Now see, when I am writing an answer for an OSCE, I will answer it in 3 words, right? The first one is, as I've said, this is the domain of critical care. First is, I will antagonize the cardiac effect of the potassium. Do you know of any drug that can be used in your wards or in your ICUs to antagonize the bad ECG problems of potassium? What is the drug that you use when the patient is having such bad arrhythmias?
Calcium.
Excellent. Is calcium gluconate. Good. So how much calcium gluconate, sir?
10%.
10%. How long do you give that injection over for? Very good. It's 10 minutes. Very good. Okay. Right. Excellent. And definitely we can, if you can give this in a bottle of normal saline, you can gradually do that. Okay. Now, remember that this calcium gluconate is important for preventing the heart from going into an arrest. Okay, so this is the immediate treatment for a cardiac problem that happens due to that. Now the second of the idea is that the potassium now needs to be, now I hope every one of you know that inside the cell, which is the thing that is more inside the cell? I ask you very simple, stupid questions. I know that. Which thing is more inside the cell? Is potassium. Okay. And which thing is more outside the cell? Sodium. Okay. We all know that. So in a hyperkalemia, what is the main problem, sir? The main problem is that this potassium, as by this crushing injury, what has happened to this potassium? It has gone out of the cell. So how do you make this potassium come in the cell? How can you make the potassium come in the cell? What is the drug that allows the potassium to come in the cell? Potassium is a very naughty man. Okay, so how do you take a naughty child inside the house? Come on. How do you take a naughty child inside the house? Okay, by giving him a chocolate or a glucose. So what we do is that we add insulin, and insulin is combined with dextrose, isn't it? Now tell me, what is the dose of insulin? What is the dose of insulin?
10 units.
10 units. Very good. In what? What is the chocolate? What is the chocolate? How much?
25% dextrose.
25% dextrose. Oh my God.
No, sir, 5%.
Okay. We use again a 5%. If you are using a 5%, sir, you need 1 liter. But I use that. I try to get hold of a 10% dextrose. If you have a 10% dextrose, it is 500 ml. Okay. So if it is a 5% dextrose, make it 1 liter and give 10 units of regular insulin. It is soluble insulin, not a long-acting insulin, please. So it is 10 units of soluble insulin in 500 ml of 10% dextrose, or 1 liter of a 5% dextrose in that. Okay. Now, in emergency condition, as someone of you have said, if you are available with a 25% dextrose, which is sometimes available in your ward, then you can have about 100 ml of a 25% dextrose. Then in that you can add 10 units of insulin. So definitely in an emergency situation, you can use 10 units in 100 ml of a 25% dextrose. But critical care people will do that. Now, the question is, how quickly does the potassium go inside the cell by your insulin dextrose regime? And how long does it stay inside? Because potassium is a naughty child. It will again come out. How long do you think it goes in? Sir, it goes by the next 30 minutes. It takes 30 minutes or half an hour for that insulin to act to keep the potassium inside the cell. But the duration of action is very short and acts for maximum of 4 hours. Okay? Right. Now in a diabetic patient, do you do the same thing? Hello?
Yes, sir.
In a diabetic patient, okay, sir, the only thing is that we like to see the blood glucose. If the blood glucose levels are more than 200, then we can omit the dextrose and we can use a normal saline for the purpose only. So definitely some people say that no, you can use 5% dextrose in a diabetic. But if he does not have a diabetes, then 25% dextrose 100 ml is a good choice. Now, anything more that can be added to increase this potassium insulin effect?
Sodium bicarbonate.
Not exactly. Anything more? Anything more?
Diuretic.
Very good. Not diuretic. Anything more? Anything more? Anything more? Remember that the main exactly. Why did you add salbutamol? What is the good thing about adding this beta 2 agonist? Is that remember that when you are adding insulin, the insulin can land up with a hypoglycemia. So people say that salbutamol produces a synergistic effect, and it is said to act equally more, is effective in this part. And remember that people say that salbutamol is equally effective, but again, the main problem for this is that you have to measure the glucose concentration and potassium, but the maximum duration is 4 hours only. So the first job was to stabilize the heart. The second job was to keep the potassium inside the cell. Now the last of the job is, if it is going to be a chronic situation, then you need a solution to remove the excess potassium from the body. So do you know of any maneuver to remove the excess potassium from the body? Excess potassium removal from the body. Definitely
Potassium binding.
See, the best way ever that has been invented is hemodialysis. That is the best thing that you can do. But now hemodialysis is not a very easy thing. So what we do is that we use a diuretic or we use a cation exchange resins. Okay. Now cation exchange resins could be sodium polystyrene sulfonates. Very difficult to get in a clinical practice. Okay. Now what we can also do is that we can use other diuretics like thiazide diuretics can be used. But remember that the volume thing needs to be controlled and you need to have a good measurement of the urine output. As I've said, hemodialysis will be the best maneuver to control potassium. So ladies and gentlemen, this is in short and summary about what you are required to know about the management of hyperkalemia in surgery. Anything to ask or anything to comment upon or any points to add?
What is the full form? Yes, sir.
Sodium polystyrene sulfonate. Sodium polystyrene sulfonate.
Yes, sir. What is the role of salbutamol?
Salbutamol is an agonist to the insulin and helps in keeping the potassium inside the cell or driving the potassium inside the cell.
Diabetic patient, then what is
the diabetic patients, the thing is a very difficult thing to add. Now you are adding insulin with glucose. Already the serum plasma glucose concentration is more than 200. So it is a very difficult two-edged sword. If you do not use dextrose when you neutralize the insulin, you may land up with more hypoglycemia. So people say that when you are having a diabetic patient, take a note that either you use a 5% dextrose, not the 10% dextrose, or do not use any dextrose, give insulin only. But the chances are that you will land up with a hypoglycemia. So that is a more problem that our critical care colleagues say that is a problem in a diabetic. But we as surgeons, even I as a surgeon will be more happy if I use a 10% dextrose, 500 ml and charge it with a 10 units of insulin. If you have a 5%, maybe 1 liter with a 10 units of insulin. So this completes this part. Now come to the next OSCE. What is this abdominal closure technique?
Tension band.
Okay, so this is various names. So this is called now tension band wearing. So this is called as a tension suturing. Some people call this as a buttress suture for abdominal support and is done for which condition? What is the pathology that may have been leading to this situation? Is technically called as a burst abdomen. And in a burst abdomen, you did that as a prophylaxis that this burst abdomen story doesn't happen. So how do you take this suture? See, the first things first is again that these sutures, if you think about the full fascial thickness of the abdomen, these sutures are taken, which is always a transfascial. That means out of the abdomen in and then in of the abdomen out, and then you keep the ends away and make a gap of about 2 centimeters from the margin. And while you have the suture in place, what you do is that you place a rubber bolster or a rubber bead, as has been used in this one, a drain pipe, and then you tie the knot over this area. Now, remember that what is expected is that whenever you are using this suture, and you are using this rubber bolster to be used, the basic idea is you are allowing the force, or you are allowing the maximum tension to be expectedly on this suture. Now the good thing about it is that your force of suture is done 2 centimeters away from the main abdomen closer. But that also means that I have seen a couple of surgeons only giving the tension suture. Remember, this is not the technique. If you are closing the abdomen, tension sutures are an additional sutures. So these ones are extra. This also means that, like the conventional abdominal closer, you will use the PDS, proline, whatever you do, and you are going to close the abdomen exactly in the same way. The 1 layer, 2 layer, whatever you do, interrupted or continuous, PDS or proline, doesn't matter. And you're required to do the same thing. So what is important is that these transfascial sutures that have been taken, these transfascial sutures are removed at 8 to 12 weeks. Remember that these sutures are going to be removed at 8 to 12 weeks. After you have removed this suture, definitely what is going to remain in the patient is this suture. So if you have not given this transfascial abdominal wall closer proper, things are not going to be happy. So this is what exactly is a tension suture of a bust abdomen. So the criticism for this is that the biggest criticism, and I am in favor, is that you are creating a big zone of an ischemia of the muscles of the anterior abdominal wall exactly in this domain where the muscles have the most important neurovascular supply of the rectus abdominis group of the muscles. And thus this tension band wearing, the buttress suturing, whatever you call that to be, again, does not prevent a hernia. So you did this to prevent an incisional hernia. I do not know whether incisional hernia is more, but definitely it does not prevent an incisional hernia. That is for sure. It gives you an immediate answer that the bowel was out and you did something to help the patient. So this completes your answer for this abdominal closer technique and the principle of use of this technique. So if you're asked in OSCE what is the principle of use, is that it is used for a closer in a burst abdomen. Burst abdomen nowadays is called as a full thickness abdominal wound dehiscence with evisceration. Evisceration means the bowel wall is out. Okay, and what is the principle? The principle is a full thickness closer to decrease the tension in the main abdominal wound. So this completes your description. Anything to ask about in this area?
So,
yeah.
They will be taking this buttress suture after the closure of the abdomen with the PDS or
no, sir. Whenever you are taking the buttress suture, obviously you cannot take the buttress suture after you have closed the abdomen. What we do is that we give the buttress sutures, interrupted ones always, and then we do not tie those buttress sutures. Then we take a PDS or proline, whatever is your choice. We close the abdomen like we do normally, and then after we have closed the abdomen, we close the skin. And after we have closed the skin, the last one to be tightened are those buttress sutures now.
Thank you, sir.
Okay, any more questions or queries? I do not think any. We go to the next one.
Sir,
Yeah.
one more query, sir. Sir, in that suturing technique, do you use that far near far technique?
Sir, you can use whatever technique you like. In an abdominal wall closer, if far near techniques are better done when you are doing the primary closer. After a burst abdomen, the biggest challenge that you are going to have with you is that the fascial edges are separated away from you. So now you need a closer. So if you are conversant with the far and near technique, you can always do that. You can always do the far and
Sir,
yeah.
sir, we will remove the tension filtering in about 8 to 10 weeks.
Weeks, not days. Not days. Because remember the abdomen wall, if you see the statistics of the abdominal wall wound healing, at the time when you have opened the abdomen, what is the tensile strength of the abdominal wall? Is 0. Abdomen doesn't have any tensile strength on its own. Please remember that. The abdominal wall tensile strength at that time has technically become a 0. Now this 0 becomes about 80% by 6 months. It becomes 90% by 2 years is the data from Mingo. So that means until and unless it has attained say 50% of the strength, do you think that it will be a wise decision to remove the tension sutures?
Okay.
Okay. Right? Chalo. So I think that I am clear with
And
this.
sir, can you just repeat about the incisional hernia thing, sir?
The incisional hernia, now why did we give this thing? We gave this thing for one single reason. We gave this because we wanted to prevent an incisional hernia. Now, under no circumstance, this thing is going to prevent a hernia because see the vascularity of the area of the anterior abdominal wall. It is really going to produce a devascularization, and this devascularization thing is not going to be a good one for an abdominal wall. Okay, chalo. Now we go to the next one.
Thank you, sir.
Right. Now the next question is simple one. What is this suture? When everyone can say, what is this suture?
So it is polydioxin, monofilament, non-absorbable.
Very good. It is everything is written. Polydioxinone suture. Now, is it an absorbable suture or a non-absorbable suture? What is your opinion on that?
Delayed absorption.
Very good. Nowadays, we call this to be a delayed absorbable suture. Good one. So this is a delayed absorbable suture. Okay. What is the chemical material that is used to make this suture? It is written in this one. Is something called as a polydioxinone. Hence the name PDS2 is the company state name. Is it a monofilament or a polyfilament suture? Is it a mono? Come on, man. What is the color of the suture? Violet. What is the gauge of this suture? 0. So now tell me, what is the specific use of this suture material?
Abdominal wall closure.
Exactly. It is an abdominal wall closure. Good one. What closure technique depends upon you? I use a single layer abdominal wall continuous suture. Now, talking about the absorption time and talking about the strength of this one. Now, whenever we talk about this absorption time, because the question has asked about, the absorption time is 130 to 180 days is the usual absorption time. Okay. Now, talking about what is the tensile strength story. Remember that in the tensile strength story, 70% of the tensile strength is maintained at 2 weeks. 50% of the tensile strength is maintained at 4 weeks. 25% of the tensile strength is maintained at 6 weeks. Okay. So please remember that. That means 6 weeks, 25% of the tensile strength only remains. So please understand that this is this part. Okay. The absorption is complete by 180 days. And what is the way that this absorption takes place? Is there some enzyme that is secreted by the macrophage which digests the PDS? Or a simple question. How is the PDS digested? No, sir. By a chemical process called as hydrolysis. By a chemical process that is called as hydrolysis. How is a visceral suture absorbed? Again by the same technique, hydrolysis. Okay. How is a catgut suture absorbed? It is by proteolysis, by an enzymatic degradation by the macrophage. So remember, catgut undergoes proteolysis, Vicryl and PDS undergoes hydrolysis. What is the inflammatory reaction that happens due to the use of PDS? Is a minimal inflammation, and hence it can be used in contaminated atmospheres also, like an abdominal wall closure. Okay, so this completes about your knowledge about the PDS, right? Now talk about this suture. Yeah, please.
Sir, what does a 0 day signify?
Well, no one knows. The 0 day means the day of the suture. If you start that, what does the 0 signify? Come on, you are going to tell me what does the 0 signify. This is something that I am going to ask you. What does the 0 signify? Ray, what is the 0 signifies? What is the 0?
Thickness of
The thickness of the suture. Can you see some other words that are also written? Can you see that the thickness is, again, the thickness is not 0. The thickness, remember, is 0 means it is according to the United States Pharmacopoeia, that they have mentioned that this is a 0 gauge of the suture. Okay. Now, if you go to the British Pharmacopoeia, this will be technically enough. This will be technically enough, a 28 gauge maybe. Now, according to the metric scale, if this is the United States Pharmacopoeia, according to the metric scale or the SI scale, it is a 3.5 metric suture. So it is all about that 0. Remember 10, 20, 30, 40. Okay. So this is the 0 means that it is a thickness of the suture. That is this one. Right? Okay. Good one. All right. What is this thing, sir?
It's a lot.
Okay. So this is a code name. Nowadays you have the QR code for this, but this is a code name for the suture. Okay, the manufacturers have given this code name. We are not going to the needle into that. Okay, by the way, what does the word 90 centimeter mean?
Length of suture.
It is the length of the suture material. Very good. So these are the small things that you are required to know. Right. Come to another suture material. What is this suture material? What is the use of this suture material?
It is catgut. Wood. No.
Array, catgut. Oh my God. Array, you saw this suture, man. What is the name of this suture? Ethibond textile. Nylon. Come on. You are not reading things. What is written in this one? Polyester. This is the polyester suture. What is the color of this suture?
Green.
Green. Come on. I am asking you simple things. It is green because what is the color of polyester as such? What is the color of? Is colorless. So why have they made it green?
Coated, sir.
Because you can use for identification. Now tell me, what is the use of this in general surgery? What is the property? Absorbable or non-absorbable?
Non-absorbable.
Non-absorbable.
Okay, that takes care of that one. This is a non-absorbable suture. Good one. Right? Okay. Now the gauge of this is 1 United States Pharmacopoeia. 4 metric. The length of the suture is 75. So now tell me important question. What is the special feature of this suture? First of all, this is pharmacologically inert. This is a non-absorbable. This is a monofilament suture. So it has a very smooth passage through the tissue. So now tell me, what is the best important quality that a general surgeon has to know about this one? Is the tensile strength. This has said to be one among the strongest tensile strength that a suture can have. So please remember that this is a very good knotting quality. Though this is a monofilament suture, the tensile strength is beautiful. and is said to be equal to a tensile strength of a nylon, which is said to be one among the strongest sutures that are possible. Now, with this knowledge, tell me, what is the use during a general or a GI surgery? Come on, Ray. I will tell you one use. If you have seen our cardiothoracic surgeons use that, this is usually used by vascular people. Because if they have to place a graft over the aorta, just imagine a suture on the aorta. How tough, how tensile strength of that suture. Hence they use an ethibond suture on the aorta. Okay. But what is the use in GI surgery? Anything that you know of?
Hiatus hernia.
Very good. For what purpose, sir?
Fundoplication.
Fundoplate, no, sir. For the cruroflexy. If this is the crura has got widened during the hiatal hernia surgery. You need this suture material to approximate the crura so that the hiatal or the repair that you have done doesn't happen, or that slippage doesn't happen again. So remember that you are below the diaphragm. So that means you need to have something that is as strong as the diaphragm and will not tear and will not produce a tissue reaction. So what is your option, sir? Is to produce a suture like this. So this completes this one. What is the use in emergency surgery, sir? We have seen your
Vascular repair.
Tendon repairs.
Very good. Like which tendon, sir? This one. Which tendon will you use for repair?
Achilles.
Exactly.
Tendon repairs.
Exactly, sir. Very good. This is used for tendo Achilles repair. Excellent doing. So for all general surgeons who are in emergency, please know that if you are doing a tendon repair, particularly the tendo Achilles is a very common one in your emergency surgery practice, please use this ethibond suture. It is a very good handling property with the tensile strength. Good job. We go to the next OSCE. What is this instrument? We need to be fast now. What is this instrument? Cockers, hemostatic forceps. Use in general surgery.
In hysterectomy too.
Come on, man. Hysterectomy, okay, chalo. Surgeons doing hysterectomy, okay, good one. Appreciate that. Thyroid surgery. I was going to ask you this one. Cocker is that thyroid chap. Which step in thyroid surgery do we use this?
So to hold the thyroid gland.
We don't.
To hold the thyroid gland with this. Oh my God.
We
I will
don't do this.
be really that scream sign on WhatsApp. I'll now have to draw that scream sign. Come on, man. You are using this cocker to hold the thyroid. No, you don't.
No, sir.
Then what is used in health surgery? Which one? The carotid artery. Ray. Sir, I use it during a mastectomy. For what structure? Internal mammary artery perforators. Remember, these internal mammary artery perforators are against a very slippery background. Now, this is a historical use. I don't use technically. I use an hemostatic forceps. But technically, it has been against internal mammary artery perforator. But probably the best use is during an amputation. What use is during an amputation? When you have transected the bone and there is a subperiosteal bleeder. What is so special with this instrument is that it helps in catching a blood vessel against a slippery background. And hence for a periosteal bleed, this is used. If you have seen during a scalp laceration, I think all of you have done a scalp suturing. How do you control a scalp bleeding immediately?
We got it, sir.
Exactly. Sir, which layers do you hold? Which layers do you hold? SCALP. The P is the periosteum. L is the loose areolar tissue. You hold your cocker with this. The skin and the epineurisis, and invert this to do the hemostasis. So these are the simple things. Now, how does it come in thyroid? When Cocker used to operate, remember Cocker's days, they had thyrotoxicosis where the blood vessels were very large, veins were there. And then Cocker had the help of his friend called Lugol, who used this Lugol's iodine to make it a blood vessel against a thick background of a vascularity. So Cocker used these instruments for thick veins and vessels on the surface of thyroid. But gradually himself stopped using this later on. But remember, Cocker had other inventions to his credit also. Chalo. After Cocker, what is this instrument? Very simple.
Suture cutting.
Suture cutting. Array. This is suture cutting. Mio. Come on, this is not a Mio one, man. This is not suture cutting, sir. Suture cutting instruments, go to your ward today. How do they look like? They look like a parrot beak, but both the instruments have the same length of the jaw. This is EPS. Array, we are surgeons, man. This is a blunt tip. This is a sharp tip.
For micropore?
Micropore, very good. This is called as a bandage cutting scissors. Array, you see, oh my God, so simple a thing. This is used for bandage cutting scissors. So we are using for micropore is a good one, but this is used for cutting the bandage. Okay. So this instrument is called as Lister's bandage cutting scissors. The blunt tip, remember, if you are cutting a bandage, if this is the bandage in the hand, which side will the blunt tip go in, out or in? In. Yes, the blunt tip is in, the sharp tip is out. I hope you understand the reason. Okay, we go to the next question now. What is this instrument? One, it is written in this. What is this instrument? I know that it is contour. Okay, anything more than contour?
Curved cutting stapler.
Curved. Exactly. This is called as a curved cutting stapler. Okay. Used for what exact step in what operation?
Low anterior resection.
Very good. Excellent going. Low anterior dissection. A good one. For which side of the specimen? Which side are you going? Exactly. You are going to use the contour in the distal margin. What should be the gap between the tumor lower border and the contour?
5 centimeters.
5 centimeter for LAR. Okay, you are a lucky man. We do not get 5, sir. We get 1 centimeter. 1 centimeter margin. Remember that. Well, if you are not happy with 1, I give you 5 millimeter margin for an ultra low LAR. Remember that the main logic of an ultra low LAR is that lymphatics are going to go up until and unless it is at the level of levator, where it goes laterally and downwards. So you are going to place the contour stapler 5 millimeter below. How does a contour help in? How does a contour help? The curvature is because the sacrum has a curvature. Okay. So this is technically the operation is an LAR, lower margin 1 centimeter or 5 millimeter away from the lower part. Good. What is this instrument?
Circular
stapler.
Circular stapler. Okay, circular stapler. Anything more for an osteotomy? Circular anastomotic stapler. Not very happy, sir. See the marking. 1, 2, 3, 4. What is this one? And it's also
From the anal bulge, mucosa.
So what is this stapler, man? What is this? Exactly. This is a MIPH stapler, not an LAR stapler. Remember that this is a hemorrhoidal stapler or a minimally invasive procedure for hemorrhoids. So this is the stapler. What is used in surgery? Sir, this is used for and stapler hemorrhoid. Okay, or stapled anopexy, whatever you call that to be. What is the grade of hemorrhoid for which you do this procedure?
Grade 3.
Very good. It is usually a grade 3 hemorrhoid. Anything more than hemorrhoid that you do this for? So hemorrhoids that are associated with a mucosal, partial mucosal prolapse. Very good. Is technically the indication of use of this one. What is the eponymous name given to this one? It's a long go statement. Okay, right. Chalo. Now, this set. What is this set for?
Sir, emergency tracheostomy.
Very good. Every one of you have identified, then I should be. I hope all of you have identified this set as an emergency tracheostomy set. Good one. So now tell me, what is C?
Retractor.
Array. What type of
Mastoid
retractor?
retractor.
Mastoid in the neck. Sir, this is a self-retaining. Self-retaining. It can be a gel P mastoid. Sir, just say self-retaining. What is this?
Skin hook. Cricoid hook.
Skin hook. Correct. Skin.
Cricoid hook, sir.
See this one. Very good. So this is a tracheal hook or a cricoid hook to do what? To do what?
To pull the retract.
To stabilize the trachea, not retract. For retraction, you have these ones. They are called as Senmiller. See this picture. See the retractor. These are the retractors to retract your wound. This one is a tracheal stabilizer or tracheal, whatever you call that to be, hook. Whatever you call that to be. What is this one?
Dilator, tracheal dilator.
Very good. So this is a tracheal dilator. Okay. Can you use this set for a cricothyroidotomy? Can you use this set for a cricothyroidotomy? What is your opinion?
Yes, sir.
Yes, you can. Remember that in an emergency, we do not, in a trauma patient, we do not do a tracheostomy. If you are still doing a tracheostomy in a trauma patient, no, sir, you don't. After 7 days of a ventilation, the emergency surgical airway of choice in a trauma patient. What is the answer to that?
Cricothyroid.
Is a surgical cric or a surgical cricothyroidotomy. Okay? After the patient has been in a ventilation for 7 days, then and then only you can change that to a good tracheostomy. Tracheostomy nowadays can be done by percutaneous, open, whatever you like that to be. Sure. Now go to the next one. Chest X-ray. What are the findings of the chest X-ray? Quickly.
Fracture.
Fracture with right pneumothorax.
Okay. White sir. Finding number 1.
Flail chest.
Real chest. Oh my God.
No, rib fracture.
Sir, I could.
Rib fracture.
Kindly do not say flail chest. At least point number 1 is rib fracture. I hope everyone is agreed on to that. Okay. Now, while you say rib fracture, let me do one simple thing for you. What did the ATLS teach us to do? It taught us to do something called as A, B, C, D, E approach. A, B, C, D, E approach like you do in an undergraduate. Okay, A. Okay, what is A in the airway?
Trachea.
Trachea. Not only trachea, sir. Talk about the lungs, na? This is the lungs. Do you notice any evidence of a pneumothorax?
Yes, sir. Right apical.
Right apical pneumothorax. Okay. Because if that is the pneumothorax, then I'm going to ask you where is the lung borders. If you have said the lung borders, okay then. So
Yes,
that
sir.
means you are trying to comment that this is the lung
Yes, sir.
which has collapsed. And on the other side, you are commenting that this is the lung. Okay, I am happy with that. And I hope all of you have identified the trachea. I marked it with an yellow color so that all of you can identify the trachea. I'm really happy that you have identified that this is the pneumothorax. Okay. If you say this is pneumo, I am happy with that. So I hope A is done. A stands for airway. Now tell me what is B. B bole to.
Bones.
Bones. Very good. Now in the bones, very quickly tell me, what are the pathologies that you see in which bones? Sir, very obvious. There is a rib fracture. There is a rib fracture. Okay. Anything, any other bones are bad? Anything in this one? Anything in this one? Anything to comment? Sir, nothing to comment. at least in a quick glance, I can see 3 rib fractures. One, this one, this one, this one. May have been a rib fracture, maybe this one also. So that means I can see in B a rib fracture. Okay, done. What is C?
Cardiac shadow.
Cardiac shadow.
That means a cardiac shadow. Are you happy with the cardiac shadow in a trauma scenario?
Yes, sir.
Okay. I am happy with the cardiac shadow. Okay. How to know you are happy with the cardiac shadow?
The shape. And then cardiac 2. Cardiac
2:1, 2:1.
The 2:1 ratio. Good one. Okay, so all of you know that from an undergraduate days that the heart shadow should be less than 1/3. Good. So this takes care of the C. What about D? D is the 2 domes of the diaphragm which appear normal. There is a liver and there is a fundal gas shadow in that. So there is nothing gas below the diaphragm. Okay, happy with that. What is E in this picture? E is something extra. Now tell me, what is these
emphysema.
things?
Surgical emphysema.
Very good. So these are surgical emphysema. Happy with that. Now tell me, what are these things?
History of some sternotomy.
Sternotomy done. Okay, good one. So this patient had a sternotomy where, now tell me, how many findings did you see? See, this X-ray has at least 4 or 5 findings. So I hope it is good to mention this. What are the findings in the X-ray? Please mention it in. Right? So I think that you will be doing this now. Now, go to the next one. What is your tag? Yeah, what about the?
Sir, how can we say that it is related to sternotomy?
No, sir. We have not said it is related to sternotomy. He has not asked you in relation. What are the findings in the X-ray? So if you have mentioned this post-CABG, sternotomy, etc., these are all other associated findings. Nothing to do with your... Okay, please do not feel that the cardiothoracic surgeon was not happy with the patient and the patient landed up with a blunt trauma chest after that. It is not exactly in that way. Okay, so now let us talk about this one. What is the diagnosis?
Pneumoperitoneum.
Pneumoperitoneum. Good one. Okay, what is the most common organ?
So generally in blunt trauma abdomen.
Generally in a blunt trauma abdomen?
Liver.
Liver, spleen, bowel. What is your opinion? Liver, spleen, bowel.
Spleen, liver, and then bowel.
In adults, what is the most common organ involved?
Spleen.
Well, not exactly. See, this is the reason I give you this controversial question. This question appears to be a very innocuous question, not exactly. If you see series, the most common organ in a blunt trauma abdomen in a child is a spleen. Given that the spleen is larger than the rib cage and the spleen is mobile and the ligaments of the spleen are lax. And hence in a blunt trauma abdomen, spleen is liable to get avulsed from the abdomen. But in an adult, remember that due to the omental fat and due to the colonic and the stomach thing, the spleen is tucked away in the upper rib cage. So there are series which says that the most common organ injured in blunt trauma abdomen in an adult is the spleen. But there are series, even I have a big series publication in which the most common organ injured is a small bowel rather than the spleen. So if you have said the spleen, I will be giving you marks. If you have said the liver, I will not be giving you marks. If you have said the small bowel, I will also be giving you marks. What is the eponymous radiological sign? Eponymous means name. What is eponymous? Football sign. Football is not a name. Okay, chalo. I know that it is football season now. Summer is in place. Okay. Very good. Which one do you think exactly is the regular sign? See, those of you who have not seen the regular, this is something I am going to mark you the place. This is something called as a continuous diaphragm sign. Some people call this to be the cupola sign. Cupola means that there are, again, looks like so 2 tombs of a minaret maybe. But now look at this one. There is air inside the bowel and
as well as outside.
there is air outside the bowel. So if you have not seen this one, again I am going to erase this thing. And now, can you see this loop of bowel? Can you see this loop of bowel? This loop of bowel in front of you is something that is called as the regular sign. Something to remember, because this is said to be the most specific sign for a pneumoperitoneum. Out of all the signs that you have, gas under diaphragm, cupola sign, continuous diaphragm, this is said to be the most effective sign of this one, right?
So here there is air inside and outside.
Exactly. This is air inside the bowel. This is air inside the bowel. But look into this one. The areas that I have highlighted. This is air both inside and outside the bowel. So that is called as a regular sign, which is the telltale sign for a pneumoperitoneum.
Okay.
What is the Yeah.
Sir, in children, as you said, that spleen is the most common when splenic ligaments are lax and spleen is large.
Spleen is large. In contrast to an adult, where the spleen becomes smaller in size. Okay? Chalo. Okay. What is the investigation shown? What is the investigation? It is
abdominal pressure.
Abdominal pressure measurement. Excellent. Now tell me, very good idea. I'm really impressed. If this is the intra-abdominal pressure measurement, now tell me an important finding. Okay. What is the grading system for this, and what is the grading system that you are going to follow? Which grading system do you guys follow? Ray, quickly. It is a recent advance 10 number question. Ray, what is the grading system that you follow? I'll take just 4 minutes with you. Remember that in 2013, abdominal compartment syndrome across the world, many people came together and they said that like we have many societies, let us meet together and let us form a society called as World Society of Abdominal Compartment Syndrome. After 2013, remember, everything that we use is their definition. Please don't say there are 14 definitions. It is not. After 2013, they have set this definition. Now, quick things to remember according to the 2013, and this has been till the latest that we have. Important things to remember. Okay. The reference point. Remember that. What is the reference point? What is the reference point? The reference point is the bladder, and this measurement line is, what is this line that I am equal to, or what is the zero reference point? Quickly, what is the zero reference point? Is the mid axillary line of the patient. Okay, right. What is the amount of saline that you have given in the bladder? After you have emptied, what is the amount of saline that you have given in the bladder? Is 25 ml of sterile saline in the bladder. Right. What is the normal IAP in a patient who is critically ill? Normal IAP. What is the? Is 5 to 7 millimeter mercury. Please remember, these ones are standard definitions. What is IAH? Is in which it is greater than or equal to?
Sir, 12
millimeter mercury. What is ACS? ACS is when the IAP is more than 20, not 25, it is 20. Please remember that. What is the grade? IAH, according to the World Society, is graded by grade 1, where it is 12 to 15 in millimeters of mercury, not water, please. Grade 2, 16 to 20. Grade 3, 21 to 25. Grade 4 is 26 or more. There are other parts of the definition, but for today, you are required to know this part. I hope I am clear in this terminology. Okay? So this is what you are required to remember. We can talk more about what is oh no, not IHS. Sorry. I should say that IAH. Very sorry, not IHA. It is IAH. Okay, right. So please remember this. This is not my definition. This is a 2013. This group. Complete. The last question and we end. What is the degree of bond?
Grade 2 superficial bond.
Anyone with any other answer, please? Okay. Grade 2 superficial bond. Anyone with any other answer, please? What is the color of the tissue? What is the color of the tissue?
Pink.
What is the color of the tissue?
Pink.
Red. What is the color of the tissue, man? What is the color of the tissue in this one? Sir, this is black. So what is this grade? What is this grade? What is this tissue? This is an ishkar. Exactly. So what is the degree of bond? So the bond is third. What is the telltale characteristic of a second degree bond? What is not absent? What is absent in this picture? Is a blister. Third degree bonds does not have a blister. Remember that. Tell me what is the imminent complication that is going to happen?
Compartment syndrome.
Okay, compartment syndrome is a good answer. And now to prevent a compartment syndrome or to prevent an ischemia, now tell me, where will you like to give the incision for an ischorotomy? Where will you like to give the incision for an ischorotomy? On the finger. Which side? I will ask you this one as a part of your MCQs now. Which side will you like to give the incision for an ischorotomy? This one or this one? The orange line or the blue line? Which one do you think should be the incision for an ischorotomy? You don't have the facility. Yes. Always remember that it is on the radial side of the finger. Now tell me about the limb. Okay, tell me about the limb. Okay, on the limb, on the arm and the forearm, okay, which side do you give the incision? Radial or the ulnar? So it is on the ulnar side. That is the difference. So what is the nerve that needs to be identified and preserved while you are doing this? On the volar aspect, you give it on the ulnar side. And remember that the ulnar nerve needs to be identified and preserved. The dorsal aspect, wherever you are doing that, remember that this is given according to your towards the thumb. And what is the important nerve that needs to be preserved at this point? Are the branches of the radial or the sensory branches of the radial nerve. So if I ask you, what is the incision which needs to be preserved while making an incision on the volar aspect is the ulnar nerve, and you give it in front of the medial epicondyle. So if I made the picture needs to be modified. The incision is made in front of the medial epicondyle. This is something that a postgraduate has to know because ulnar nerve is behind the medial epicondyle. In the leg, definitely remember you have common peroneal nerve and nerve and the OSCE set for the day. Sorry. This completes your OSCE set for the day. Just a minute, my screen sharing went off.
ऑनलाइन ही तो क्लास चल रहा है और 2 महीना तो पढ़ाई हुआ है जून जुलाई मान लो हाँ
Sir will be joining us. Okay. So, ladies and gentlemen, any more questions, please? We have completed 15 OSCEs. So, how was the OSCE set? Was it easy? Was it difficult?
Just moderate.
Moderate. That is a diplomatic answer. Okay, good enough.
Good, sir.
Okay, so I hope all of you.
I have a doubt.
Yeah, go on, please.
Sir, the incident for escharotomy will be on the lateral aspect, right, of the limbs.
Lateral aspect of the limb. Lateral aspect of the limb if you are doing it on the extensor side. Escharotomies, sir, are not a fasciotomy. Remember, escharotomies are given across on the plantar, on the flexor aspect as well as the extensor aspect of the limb. Remember that the basic logic is that this is a cylinder. Now, the cylinder is being covered by a 60-degree thing. So, this is the start. So, if you are releasing the 360-degree, it is to be released not only like this, to make it release like this also. So, the release has to be on two sides. Okay? Right. Anything more, please?
During electrical burn injury, sir, for escharotomies, we will follow this only.
See, I do not know of any other special rules for an electrical injury. Because the third degree burn, I think that this will be the single rule. Okay, any more questions with any more queries, please?
Sir, for the fingers, it will always be on the radial side.
Yeah, finger, it is always good to do on the radial side. See, the basic logic in the finger is that you don't incise on two sides because the neurovascular bundles are on each side. If one of the neurovascular bundles are cut, you can still do away with the other one. Okay, so this is the reason it is given on the radial side. Other questions, please? So this OSCE today was mostly in relation with general surgery. So if you have seen your general surgery, we talked about instruments, surgical safety, we talked about fluid electrolytes a bit, we talked about bonds and talked about sutures, etc. Okay? Any other questions, please? And I hope you will remember this undergraduate style of teaching IV cannulas. So with this, thank you everyone. Have a cup of tea by the time Professor D.K. Sarkar joins. Okay? Thank you then.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
So Sarah's joined for him.
कब क्लास करना है?
Do you think that I should give them a break for 5 minutes or I can start right away?
Sir, we can start after 5 minutes, sir.
Okay. In the meantime, if I could share my screen.
Sir, I have enabled, sir.
Yeah, thank you very much. I think I am visible and audible, Shilajit.
Yes, sir, it's visible, sir.
So I can do a 5 minutes break and I come back in 5 minutes. Okay, I'm there.
Okay, sir.
doing the screen sharing. Very good evening, everyone. Hello.
Yes, sir. Audible, sir.
Right.
Good evening.
Yes, good evening, everyone. Like as we do for the last of the couple of OSCEs, I always show you the questions, take 5 minutes in writing the questions, and then we'll proceed to this part. Today I have done, apart from images, there are 2 videos also, because I thought that we'll be graduating ourselves. And with this computer-based examinations, videos should be the norm of examination. I think we should start now. Ready, everyone? Can I start now? Hello?
Yes, sir.
Right. You are being shown a device on one side of the screen. Question is, identify the device. What are the local complications at the active electrode in open surgery? What are the common local complications at the return electrode? If you have completed, then please. Hello. Have you completed, everyone? Can I proceed? Can I proceed? Now, you have been shown the device. Now, with the device, I am showing you a current waveform. Identify the current waveform used in this device from question 1. And I should add one point also to this question. Sorry. And I should add one point, ladies and gentlemen. And mention 2 complications specific to this waveform. I hope my handwriting is readable. Mention any 2 complications that is specific to the waveform. So, if you have completed, please. Can I proceed?
Yes, sir.
I think on your screens there is a picture of a device that you can see. Okay, this is a common thing that you use more or less every day. Questions are identify the device. There has been something called as a part A. This is very clear in your screens now. What is this part called as a part A? Last question is, what are the zones of injury associated with this instrument in minimally invasive surgery? Can I proceed? Can I proceed? Hello?
Yes, sir.
Now, this is a video. So I'll show the video. Okay. A 4-week male child was brought with this presentation. Okay.
Yes, sir.
Chalo. Done. So if this is the video to be shown, then what is the clinical diagnosis? What is the investigation of choice? And what is the treatment outline for this patient? This is a very simple question. So I should have said investigation of choice criteria. Very sorry. I should have added this word. There is an amendment criteria. Okay, can I proceed?
Yes, sir.
Now this is an interesting question. You are being shown a chest X-ray and an X-ray of the abdomen. This, now you have to tell me the clinical presentation in relation to this imaging. What are the outcome determinants for the long-term survival? I do not need the treatment. I know all of you will know what is the treatment to be done. What I require from you is what are the determinants that this patient is going to live, or what are the prognostic indicators in this patient? Okay, done. I think we can proceed now. Hello.
Yes, sir.
Good. Let us proceed. This is a 6-week-old male child who presented with a groin swelling. You can see the clear picture. Okay. What is the diagnosis? What are the complications? And what is the role of minimally invasive surgery in this patient? Hello.
Yes, sir. It's good.
Okay. Sorry. If you're done, please tell that to me. Okay, done. I think we proceed now. Okay, now this is an interesting, again, another video question. See the video first. Just will burst out medium. Okay, I'll play the video once again. Yeah, okay, if you've seen the video, the question. Okay, then can I proceed?
Yes, sir.
Question 8. Identify the device.
Hello.
Yes, sir.
Done? Okay. Right, I think we should go back now. Completed? Completed?
Yes, sir.
Yes, sir.
you completed?
Yes, sir.
Sorry. Completed? Complications of size more than 10 complications is located in the left lobe. Hello. Shilajit, am I audible?
Yes, sir.
Okay, I told you. We are going to have a wonky connection today. Okay. Okay, done. Hello. Ladies and gentlemen, when you have completed, kindly. Hello.
Yes, sir.
Hello, am I audible, Shilajit?
Yes, sir.
Hello.
Sir, audible, sir.
Okay, come on, man. Respond. Done? Sorry.
Yes, sir. Right.
Hello.
Okay. Sorry. Can I proceed? Come on, guys. Time is short.
Yes, sir. Yes, sir. Hello.
Last question of the series. And then
Sir, the screen sharing went off, sir.
Shilajit, am I audible?
Yes, sir. Audible,
Yes, sir.
sir. Sir, the screen sharing went off, sir.
Shilajit, am I audible?
Yes, sir. Audible, sir.
Okay. I told you this internet connection is going to get wonky. And you have now the last question in the series. Should I go to the question 14 once again?
Yes, sir.
Okay. This is the question 14. think you have completed now? Hello.
Yes, audible, sir.
Done? So, ladies and gentlemen, we have completed the first 15 questions of today's OSCE set. I think today's OSCE was the easiest out of the lot for the last OSCEs that I have been taking. Hello? Completed, everyone? No. Okay, I think you have completed now. Okay, then. Let us start then. The first question is, the first query from all of you is, what was the level of difficulty of this? Hello? Level of difficulty level for this? Tough, easy, very easy. What is your opinion?
Tough, sir.
Tough. Oh my God. I feel this is the easiest one, man. All questions were at undergraduate level.
So not the device, but don't know about the electrode system there.
Okay, but sir, this topic, believe me, I am not asking this question only. I am asking you for all the questions, the next of the 15 questions. They were easy, I felt. Okay, right. Chalo.
Yeah, quite easy.
They were quite easy. Good enough. Now, what is this device? Let us come back to the answer really quickly. What is this device? What would you call this device to be?
Monopolar electrode pottery.
Very good. So this is technically called as, now in a real world, this device is just no. So this device is called as a monopolar diathermy active electrode, also called as, the technical name for this is an active electrode. We also call this as a diathermy pencil. Okay. Some American books will call this as a Bowie in honor of the gentleman who, along with Harvey Cushing, invented this monopolar diathermy. Okay, so this is technically called as an diathermy electrode, diathermy pencil, diathermy probe, whatever name you like to call this to be. But if you have written all of this examination in an examination, remember these are all accepted answer, including I will be giving you marks for if you have written the movie. Because there are still some surgeons, particularly some senior surgeons, who may like to use the term movie till now. Now, before you understand what is this thing that goes on, what is this monopolar system? The monopolar diathermy, technically always remember this electrosurgical units for your examination purposes. Now, not only examination, maybe for life, because I do not know of any operation that I will be doing without diathermy, maybe circumcision. That is the only operation that I can remember that I do without using a diathermy. So now in a monopolar diathermy, what is important is that, please understand, the normal household current is an AC current or alternating current that looks like this, and this is called as a sine wave pattern. Now, when we say this current is given to a muscle, or nerve and muscle apparatus or this. What happens is that the nerve and the muscle will undergo contraction and twitching. And then if someone gets electrocuted, they have this dancing like movement. But this is called as technically the frequency of current, which is usually 50 hertz, which is a normal frequency in the Indian subcontinent. Now, when we talk about the rest, if you increase the frequency of the current to more, remember that, and make it 3 to 5 megahertz, then what is important is the nerve muscle conductivity or nerve muscle contraction stops. So this is the first basic fundamental that the machine that is generating the current. So that means if this is the diathermy machine, what this diathermy machine is responsible for generating is it is taking the feed of the AC current from your room, and after it is taking the AC current, it is generating a feed of not a high voltage current, understand, for a high frequency of a current. And that current is not going to produce an electrocution or nerve muscle contraction. If the diathermy that you are using is producing too much amount of nerve muscle contraction, probably the transformer in the or those conductors in the diathermy machine are not off, or the current quality is not good. That can be this important. Now, when I talk about a high frequency of current, what do I exactly mean? I mean that between the 2 points A and B, what is very important is that you are allowing the electrons to travel like this in the sine wave pattern. So when you understand that if this is something, that means see the graph again, because question 1 and question 2 are related. If you make a graph between the voltage versus the time, consider the first of the currents to be a complete something called as a cutting current. Now, what is a cutting current? Cutting current means you are allowing all the electrons to pass exactly like the way you did, and over an unit of time. Say, for example, the time gap between that I have mentioned is, say, for example, 10 seconds. So this is an example. And out of 10 seconds, you are allowing 100 electrons to pass. So these 100 electrons are having their time, and they are coming at one point, and then immediately at one point of time. Now please understand these dots that I am making for you guys. So can you see that if this is the tissue, say for example, these dots are the tissues, what is the time that each electron gets to stay on the tissue? The answer for this is very small. The answer for this is technically very small. So what is the big deal in this? The big deal is that as I've told you, the main effect of the current, that is always equal to the heating effect of the current. That means when you use electricity or electrons are coming down, so if this is the tip of the pencil and electrons are coming to the tissue, the electrons are transferring the energy. Energy is going to get transferred to become heat, and the heat is going to produce that amount of minor burn injury. And the burn injury is technically divided as a cutting current. Okay. But this cutting current, so if you understand that tissue, the answer for this is it happens in such a point that you get a cut in the tissue, and the amount of the lateral zone that is generated by the current, remember the amount of the lateral zone that is generated by the current will be, or the amount of heat burn that is generated by the current is very minimal. Say with a depth of around 1 millimeter only. So this is the logic about using something called as a cutting current, in which all the waveform cycles are used. Can you tell me cutting current is indicated by which color on the probe? No, I'm asking you a simple question to a group of senior surgeons. Yellow. Okay, the yellow one. Very good. So this is the cutting. Right. The other one is the blue, which is the opposite of this, called as a coagulation. Now, what is this coagulation system? The coagulation system means, now understand, the cutting is done. Now tell me, if you use a cutting, that means what is the advantage of cutting? The advantage of cutting is the amount of burn that is produced is very minimal. What is the advantage? Another point. So the depth that it produces is big, and the depth is associated with tissues are cut. What about hemostasis? What is your opinion on hemostasis with use of a cutting current?
Less hemostasis.
Okay, there is less hemostasis because tissues are known to cut. So if there is a vein that is in the pathway, as you can see in the picture, the vein, the two ends of the vein are cut, and the amount of the bleeding that happens is not stopped because the heat that is produced, as you can see in the picture, is really very minimal. Even the heat has not reached up till the vein to produce the clotting effect. So this is something called as a cutting current. And can you tell me in which tissues do you really use the cutting current? Skin is a very good, okay. So sir, in an open surgery, I will use it for cutting the skin. Sometimes even cutting small benign tumors like a papilloma of the skin. Right. Now we'll go to the other side of the story now. Now you say that when I have cutting, I need something called as a coagulation. So what I will do is that I will use the same number of electrons, that is 100 electrons. But in this 100 electrons, what I will do is that I will deliver the 100 electrons over a small part of time. And as you can see, I have delivered 50 electrons over a small part of time. And the rest of the 50 electrons are derived at this point. Now, it is basically like having a musical chair-like arrangement. If you allow everyone to run across a musical chair, which we used to play when we were in school, so think of the same musical chair-like arrangement, except that in this arrangement, understand that the waveforms down here or electrons are getting to stay at one point of time for a long time. And when you are allowed to stay at one point, say for example, you have a collection of 30 or 100 school students. When they are running around, they are not making any noise. But when they are not running around, or when the teacher has not come, can you see what is the amount of voltage that they are generating? So definitely, what is important in a coagulation current is, appreciate this part, is the amount of the voltage that it generates. The voltage that it generates definitely will be associated with one bad complication. Can you tell me what will be the complication that will be when there is an increased voltage in the tissue? That means if I make that picture again of the tissue that has been cut, what is the first thing that is going to have? The first point is that the depth of the cut is not going to be that great. But what is important is, whatever is the depth, what is the lateral thermal effect of the current? The lateral thermal effect of the current is going to be large effect. This lateral thermal effect of the current, remember, is about with a distance of about 7 millimeter. Now that's great, guys. 7 millimeter on each side out from the time of the bleeder. So that means if you have a vein that is in the pathway, you can very well appreciate the vein is completely charred. So that is technically what is a coagulation current. And if that is a coagulation current, can you tell me what are the complications of this then? Can you tell me any two complications that is going to happen to this waveform? This is called as a pure coagulation. So what is the first bad thing that is happening in this?
Sorry.
Come on, guys. Think over it. Charring. Okay. And if there is more charring, all of you have done open hernias. If there is more amount of charring, so what does your teacher say? Don't use that grade. Nerve injuries, necrosis. So the first complication is, the more is the amount of charred tissue, the less is the wound healing. And more are the wound complications like a wound infection. You think everyone will agree with me? Because the charred tissue will act as a nidus for the bacteria. Number two, what is more important in a minimal access surgery is lateral damage. If you are using this to stop a bleeding at the Calot's triangle, what can be the lateral thermal injury done?
Artery.
Say, for example, you decide that I'm going to do a pure coagulation on the cystic artery. What will come within the 7 millimeter radius of the cystic artery? CBD. The CBD. So please remember that this is the reason, for this single simple reason, never try to produce a charring effect on the cystic artery with the coagulation. I have seen many people do that. What they do not understand is the cystic artery will be coagulated, no issues on that. The diathermy is powerful enough to clot the cystic artery. Make a 7 millimeter radius. Or the patient lands up with a delayed bile duct stricture. That is a very dangerous complication. Hence, two complications are delayed wound healing and charring of tissues and lateral damage. And we have also known about cutting. So now can you tell me, can you make a compromise between cutting and coagulation? Can you make a compromise between cutting and coagulation? On cutting and coagulation, cutting has no hemostasis. Ulceration is not exactly the right word. In your diathermy machines that you are going to see tomorrow or even today night also, there is a mode that is in your machine called as the blend. Blend is so simple in life. You have one, say, a sabji, which is very sweet, and you have another one which is very spicy. What is the thing that you do in a real life? You mix them. Blend 1/4 has typically about 60% of a cut and 40% of a coag. A blend 2 technically has a 50 cut, 50 coag. Blend 3 has coag and 40% of cut. Now, it all depends upon what is the machine that you are using. So, for example, I have one very advanced machine in my data, which allows me to exactly titrate which blend you are going to use. Now, let me ask you an interesting example. I am taking out a skin wart or a papilloma under the skin. Which modality are you going to use, or which setting are you going to use? You are taking the papilloma in the skin. Blend 1, okay. Blend 3. Oh my God. Acha. Why do you need a blend 3, sir? Cutting and coagulation, isn't it? So I will probably be using a blend 2. Okay, right now. Thyroid. Charring of the tissue. If you have more charring of the tissue, that guarantees you having more seroma. In a thyroid and a neck, exactly, and a flap necrosis. Remember that if you are making a flap, probably I will be making a blend 2 or even a blend 1. That is done. But I am doing a liver resection, say rat coli. Then what blend will you like to have?
Blend 3.
A blend 3. Why don't you not a pure coagulation, sir? Why not 100% coag? Exactly, sir. You have to cut also, na?
Yeah.
If it is only if it is only producing a coagulation, come on, guys, I need to cut the tissue also. So I need a blend 3. Well, as I've said, blend 1, blend 2, blend 3s are proprietary materials. modern day machines. So for example, if you use a Valley Lab machine, if you use a KLS Martin or the Johnson & Johnson, these machines are extremely intelligent machines. They will give you a catalog about what blend you would like to have. But definitely I feel that it is a surgeon who decides. So for example, if you are doing a TORP, what blend will you like to have? TORP, I think you know, is something in which the water gets, there is some glycine as an irrigant and you need to cut the prostate.
Blend 3.
Very good, sir. TORP is technically a blend 3. Because prostate is a vascular tissue, so there is little amount of hemostasis. But I will be having a mixture between cutting and coagulation. So I hope I have made you understand about this blending things. Now talking about what are the complications, I'm taking a long time, I know that, but still I feel that this is an extremely important part to be discussed for not only an examination, but probably for your life also. Now, that my electrosurgical unit lecture is a 1.5 hours lecture I'm coming to tell you about. Now, what are the important common local complication? Now, can you tell me what is the important common local complication by this thing? Come on, man, we have discussed. What is the common local complication? Sir? Charring. Burns, charring or burns? Right. Now, when you talk about burns, that is an interesting point to understand in this burns business, in this part. When I'm talking about itself of the burns issue, see, the basic thing is about how does this monopolar thing work? Now, this is the machine, or this is the diathermy machine. Now, this diathermy machine is generating electrons, okay? So, this current, about electrons, whatever you call that to be. Now, what I'm doing is that I'm taking all these electrons are coming and all these electrons are concentrated on this. So, what I will do is that I will make a big arrow for you to understand. Please understand that this big arrow that I have made is this large number of electrons are coming. But at the end, what is the surface area of this part? These are the two buttons that you know about. Okay. Now tell me, what is the surface area of this? Surface area? Very small. So if the surface area is very small, now consider that this is the patient. Okay. Now, when there is a narrow surface area, say for example, a room has a single door and there are 100 people coming out or in this room. Now there is a fire alarm. What do you think is going to happen at the door? Come on, a simple thing. What is going to happen at the door? There is going to be a friction. There is going to be a fight between all. So that means you have the current effect or the heat effect at this point. Now the circuit needs to get completed. If not, then how can you complete the circuit story? So for that one, what we have done is that we have placed something called as a return electrode. Now, see the surface area between the active and the return electrode. Now, in this active surface area, this is the electrons which are coming through this pathway. And now you are completing the circuit once again. And what I would like to do is that the same electrons are again returning back. So now tell me, what can be the complication at the active electrode? What can be the complication at the passive electrode? If you have understood this circuit business. So number one is that in the active electrode, one important point, I do not know how many of you have known this principle. If this is the active electrode, to produce the effect of cutting or coagulation, today we have a big thunderstorm. Before taking this class, I say, wow, man, oh, this is great. Before I'm taking the class, God again made me a reminder that please teach them. This is the way thunder goes from the clouds to the earth. So if you want to have a cutting effect, remember that these are the thunder. If you want to have a coagulation effect, what is the difference between the cutting and the coagulation? Is only the thickness of this lightning. It is technically a lightning. That means to have a cutting and a coagulation effect, please remember, you are required to maintain a millimeter gap between the probe and the tissue. How many of you do this in cutting and coag? An honest confession. How many of you do this thing? Hello? No one?
Yes, sir.
You
No
do
one.
that. No one does that. Do you know what is the something that we do? We press the cutting and the coag and we touch the thing on the tissue. The minute you touch the thing on the tissue down here undergoes only one effect, something called as desiccation. It dries up. And the cutting and the coagulation effect that you wanted to have, it doesn't exactly occur in the way you want it to have. So the only lesson from today's class is, the next time or today evening, if you are planning to do an operation, just hold the active electrode a millimeter away from the tissue, just a millimeter away. And if you want a coagulation, say for example, there is a raw surface and you need a coagulation, please hold it 2 millimeters away and see the beauty about this lightning. This is how the principal thing works. And if you have known about this, I feel that you have known what is the local complication. The local complication is usually an heat effect or burn. Can you tell me what is the complication at the return electrode?
Contact.
Very good. So the basic problem is, now consider that the return electrode has a surface area that is at least 100 times more. Say for example, there is 100 centimeters square of contact. Now, by some funny reason whatsoever, the assistant or the OT theatre nurse did not understand the physics for today's class. And what he or she did was, what he or she did was, they made a contact somewhat like this. Can you tell me, this contact is now only 10 centimeters square.